We thank you so much for coming. It is so nice to see everybody here, and hope that you get a lot out of this today. I am Sherry O'Grady-Fox, the Ottawa support group leader, and I just wanted to introduce Jackie Herman, CNETS Canada president, who is here with us today and gets the funding for us to be able to have events like this. And a real thank you very, very much to the doctors that are attending today of their own free will and time. We really appreciate that you are coming today and ready to answer our questions and concerns. So we do appreciate it so much, doctors. So, Jackie Herman.
Thank you so much. I'm just going to try and get rid of this reminder here. There we go. So as Sherry said, my name is Jackie Herman. I'm the president of CNETS Canada, and I too want to welcome everybody here today. It's great that you all came out, and thank you to the doctors as well. I also want to welcome our online participants. We are webcasting this session for the first time. Can't hear me? For the first time. So welcome to everybody online. We have people joining us from across Canada and even a few people from the United States. So I think that's an excellent turnout. As you know, we have an excellent lineup of doctors today, and there's been one change to the agenda. Dr. Maroon will not be presenting. He sends his regrets, his sincere regrets, but Dr. Zvetkova will present in his place. So I'm sure she'll do an excellent job. Before we get started, I just want to take a few minutes to tell you a little bit about myself and let you know about some of the things that we're doing at CNETS Canada for the neuroendocrine patient community. So I was diagnosed with neuroendocrine cancer in 2008. I had a small bowel primary and liver metastases. In October of 2008, I had surgery on the primary tumor and debulking of my liver. And so after that time, luckily, I'm doing extremely well. My treatment is going well. I think I'm very fortunate. And it was at that time, probably about a year later, that I connected with CNETS Canada through the Toronto support group and Maureen Coleman, who a lot of you probably know. So I started attending the meetings, and then Maureen sucked me in to volunteering, and it didn't stop from there. I joined the board of directors in 2011 and started serving on the executive committee a little bit later that year, and I was appointed the president of CNETS Canada towards the end of 2012. And I have to say that it is an honor and a privilege to serve in this role and to serve this patient community. It is an extremely rewarding experience, and I've learned so much in the past year and a bit. So I'm very pleased to be able to represent this patient community. So I will get on with telling you a little bit about CNETS Canada and some of the work that we're doing. These types of sessions that we're having here today is the format that we're going to roll out for the rest of Canada for this year. So in the past, CNETS has done some larger patient education sessions, a lot of medical professional education at the same time, but we decided for the short term to focus on the patient education sessions. So in addition to the one that we're doing here today, we are going to have a session in Halifax, hopefully in September of this year is what we're planning for. We'll be in Edmonton in October, and then we're going to hopefully be in Vancouver towards the end of the year. That's not confirmed yet, but those are our plans. As most of you know, we've rolled out the new patient handbook, which is an excellent resource for the patient community. And we have hard copies here today for anyone who hasn't received one. They're at the table on the side there. They're also available online. You can download a copy. And if anyone online doesn't have a copy and wants one, they can just drop us an email or visit our website, www.cnetscanada.org, and we will get a copy out to you. Another area that we're doing some work in is trying to partner with some of the medical professional associations, particularly the gastroenterologists and the endocrinologists. A lot of neuroendocrine patients end up within those two specialties after they've gone to their family doctor complaining. And so we want to try and raise the awareness and the education among those two specialties so that they know to refer the patients to oncologists. So we are looking at partnering at the moment. We're in some very early discussions with the Canadian Association of Gastroenterologists. And we're potentially going to look at putting together a accredited program for the gastroenterologists. It'll be an online program which they'll get CME credits for, which will be their incentive to actually to work through that. So that's something, it's in the very early stages of development, but we're hoping to pull that off and then perhaps roll in the endocrinologists and tweak it maybe even for family physicians and so on down the road. So that's an area that we're working on. So CNETS Canada brought on a project manager this year, Louise Binder, who's sitting right up here at the front. Louise and I started working together probably about a year ago at this time. We were having an issue getting access for some of the patients, publicly funded access to a couple of drugs that you're probably familiar with, Sutent and Afinitor. And I'd had some patients come to me for some help. They needed assistance with their insurance copay. It was just way too pricey, and they weren't covered under the provincial programs. So I was very frustrated, didn't know what to do, wasn't getting very far on my own. So I connected with Louise, and we started appealing to some of the provincial governments, particularly in person with the Ontario government, to try and push forward the public funding for those drugs. And we had a lot of good success. And even more success came after that when they were rolled out to even more of the provinces. But we really hit it off, and it was great work that she did on our behalf. And so I decided to try and get her to work with us, and she agreed, and things are going well. So the areas that Louise will work in is she's going to handle organizing sessions like these, our patient education sessions. She's managing our volunteer training and development, and she's managing the board committee coordination, resource development, and obviously health policy advice, which is the area that she is very strong in. Louise has a very long history in the NGO sector, and she co-founded the Canadian Treatment Action Council, where she was the chair for 15 years. So she sat on numerous government advisory committees at the national and the provincial level when it comes to healthcare. So she's got a lot of experience, and we're very thrilled to have her as part of our team at CNETS Canada. So around the time that we brought Louise on board, we had established our Patient Treatment Access and Health Policy Committee at CNETS Canada. And it was because of some of the challenges that patients were facing getting access to drugs. I really felt that we needed to bring a group of people together to brainstorm and focus on moving forward on the initiatives that affect our patient community. So the committee is made up of board and non-board members. And so a couple of areas that we're working on right now, just high level, is the first one is the PRRT and gallium-68 scan access to neuroendocrine patients in Canada. A lot of you are probably aware that this was a treatment, the PRRT, was available in select centers in Canada. It was through a special access program, which was it was stopped for a period of time. And I understand that now some of the clinical trials are starting up again in some locations, or will be hopefully very soon. But the gallium-68 scan is not accessible to us at the moment. So that's something that we would hope to see. So part of the role of the committee is just making sure that we stay on top of this issue and making sure that the interests of our patient community are represented. Louise and I have, and Louise specifically has engaged with Health Canada, some of the provincial cancer agencies, and obviously we're staying in touch with the doctors who are, providing these treatments and scans. So, that's one of the areas that we're on top of. The other area that we're doing a little bit of work on, and Louise is leading the charge on this, is the P-coder transfer to Cardiff. So, as Louise and I started working together on some of these issues for neuroendocrine patients, we started realizing the value in understanding some of the health systems that impact the things that go on behind the scenes and our access to drugs and so on. So one of the health systems is called the Health Technologies Assessment. So what that means is experts in oncology look at the research about drugs and they recommend to the provinces whether or not they should put the list of drugs on their formulary to be paid for. And so this organization that does this for cancer drugs specifically is called PCODR, which is the Pan-Canadian Oncology Drug Review. It's, from our perspective, an effective organization. It takes into account what patients have to say about the drugs and their experience with the drugs, and why the provinces should pay for it. The recently health ministers decided to merge this group with another group that does the same kind of work for non-cancer drugs. And although this sounds fine on the surface, we're concerned about the decision because the other group, called the Canadian Assessments in Drugs and Technologies, CADTH, is not as efficient. It currently has a backlog of about 18 drugs waiting to be reviewed, and it doesn't listen to patient input as much as PCODR. And it doesn't rely on the same specific level of medical expertise to do its reviews. So along with many other cancer groups, we're worried about this and what the impact will be on our access to cancer-specific drugs down the road if this goes ahead and is put in place under the same process that CADTH uses right now. So as I said, Louise is leading the charge on this. She's brought together, right now we have about 10 other patient groups who are working with us to make sure that our interests are put forward. So as you can see, we're working on some things that are very specific to neuroendocrine cancer, and we're also working on things that are specific to or actually for the broader cancer group, which impact us. They're not necessarily about neuroendocrine, but they definitely impact our ability to get access to drugs and treatment options and so on. We're also participating in the CanCertainty campaign, which is the campaign that talks about the issue of oral cancer drugs versus IV. So if you go to the hospital and you get your cancer drugs through IV in the hospital, everything is paid for. If you are given an oral drug, which more and more of them are today, it's your responsibility to figure out how to pay for it. So there's an inequity there. So the CanCertainty campaign is addressing this. And so I'm sure some of you have probably heard from this group already, but you should check out their website at cancertaintyforall.ca. There's about 34 organizations involved in the group, and CNETS Canada is one of them. We're part of the coalition. And they're actually doing a little survey right now. So if you have an opportunity to go to their website and complete the survey, that would be great. They can use the input. So the other group that we are part of is the INCA, the International Neuroendocrine Cancer Alliance. So this group was formerly known as the Worldwide Net Cancer Day Alliance. And Pierrette Breton, who is up here at the front table, and a lot of you here in Ottawa know Pierrette because she's a patient in this area, is on the board of directors of INCA, and she's very involved in the group, and she's the Canadian representative as well. So members of the group are organizations like ourselves, like CNETS Canada. They're patient advocacy groups. And their key focus is to raise awareness of neuroendocrine cancer in the healthcare community and the general public. They also encourage early diagnosis by working collaboratively with the healthcare community and the public. And they recognize universal access to high-quality, multidisciplinary care and dissemination of accurate and user-friendly information about neuroendocrine cancer. So one of the initiatives that INCA has put together is they're working with Novartis to pull together the very first ever global net cancer survey. A lot of you have probably received an email about this survey already and could quite possibly have completed it. But doing so is an opportunity for you to share your experiences with net cancer and how the disease has impacted you. By completing the survey, you can help bring light to the need for greater global awareness and education about net cancer and help the experts better understand the implications of our disease and how, in turn, they can assist our community. So if you haven't already done so, please complete the survey. We were looking for about 200 participants in Canada, and we're not there yet. So if you haven't done so already, there's little flyers on your table with the link address to complete the survey, or you can go to our website again, and there's a link on there. So obviously we continue to fund NET-specific research. CNETS Canada has funded about $240,000 worth of research over the past 4 years, which has been matched by the CRS. And we'd like to continue to be able to do that. We have four separate projects. But in order for us to do so, we need funds. It obviously costs money to do research and to do all of the work that Louise and myself and those of us on the board of directors of CNETS Canada are doing every day. So we have 2 events scheduled for this year so far. We have the Strut Your Stripes event in June, and I know that Ottawa has been a very strong supporter of our annual NET research fundraising, so thank you to everybody in this room and out there who's participated. It's a very strong group who has fundraised amazingly over the last several years. So we're going to have, hopefully there'll be an event here in Ottawa this year. We're having a walk in Toronto on June the 14th, and we're actually dedicating that walk to the memory of Maureen Coleman, who passed away last year, our former founder and past president. Maureen created the Neuroendocrine Walk for NET cancer research, and so we thought that it would be fitting to dedicate our function in Toronto to her, which is where she started doing the walks this year. We're also, our Brampton group is going to have a Strut Your Stripes garage sale. It's going to be a little bit smaller scale, but hopefully we'll have fun with that and raise some funds. The other event that's going to take place is later in October this year for those who are in and around Toronto. CNETS Canada is a registered charity with the Scotiabank Toronto Waterfront Marathon. So we'll have a team there led by me, and yes, I'm going to try and run. Not a marathon, but I'm going to try and do 5K. So we'll see how that goes. So if you're able to participate in our events or fundraise, that would be fabulous. If you're not able to get out and do that, we would obviously welcome any donations that you have. We actually have a piggy bank here in Ottawa today on the table for anyone who has loose change, and there's some flyers on each of your tables with instructions and details on how you can donate to us if you like to. So for our agenda today, just a few items to note. We're going to ask that you hold on to your questions until the Q&A period. If you don't want to stand up and ask your questions, you can write them down. There's some slips of paper on each table for questions, and you can give them to either Pierrette, Sherry, myself, or Louise, and we'll make sure that your questions get asked. Online participants can also ask questions. And for those here in Ottawa, we've given you hard copies of a survey you should have received when you came in. If you could please complete, there's actually 2 surveys. One is specific to this session, and the other is just a general survey about CNETS Canada and the services that we provide. So in addition to Sherry thanking our doctors, I would also like to thank them as well for taking the time to come out here today. And I also want to thank our sponsors for this event, who are Novartis, Pfizer, Lexicon, and Janssen. So without their financial support, we really wouldn't be able to pull this off. So with that, I'd like to hope everyone enjoys the session. And now I'm going to pass it over to Pierrette, who is going to introduce our first speaker. And I don't know, maybe Fred could come and get Rachel's presentation up.
Good morning. Glad to see such a large crowd here today. Thank you very much for joining us. I'd like to introduce our first speaker. Am I to go ahead? We're ready?
Sure,
Our first speaker is Dr. Rachel Goodwin from Ottawa. She's one of our own. Dr. Rachel Goodwin completed her medical school, internal medicine, and medical oncology residency at the University of Ottawa. Dr. Goodwin went on to complete a 2-year investigational new drug development fellowship at Queen's University. She is an assistant professor in the Faculty of Medicine at the University of Ottawa. Her clinical interests include gastrointestinal cancers, neuroendocrine cancers, and new drug development. She is currently co-chair of the Gastrointestinal Tumour Board Conference at the University of Ottawa and is an active clinical investigator for drug development and trials. So let's welcome Dr. Rachel Goodwin.
So thanks so much. It's a pleasure to be here today. I must admit what I'm missing is the alternative was going to Toys R Us today and buying Lego. So actually I'd rather be here, believe me. There's 2 birthday parties coming up with my kids. So really pleased to open the session, and I was asked to kind of give an overview of neuroendocrine tumors in terms of setting the stage. And so I titled it The ABCs of Neuroendocrine Tumors. And hopefully by the end of this talk, you'll be looking like this guy, feeling more invigorated, as opposed to the Z's of I put you to sleep. So let's hope for the first one. So objectives. So we're going to look at what is the neuroendocrine system, quite simplistically, but just to throw out a definition, where can neuroendocrine cancer start in the body, some general statistics about neuroendocrine cancer, diagnosis, discuss a bit about the pathology, what a biomarker test is, imaging, and a bit on the classification of neuroendocrine cancers. So I'd like to thank a few of my colleagues. They've shared slides with me today, so I should recognize that. So what is the neuroendocrine system? Quite simply put, it's an interplay between 2 other systems in the body, the nervous system and the endocrine system. And an example, essentially, of this is the neuroendocrine system that's made up of many neuroendocrine cells. And the basic definition of that is this is a special group of nerve cells that can function in terms of hormone production. So the example that we experience every day is that when we eat, nerves feed back to the brain. The brain feeds back to various organs within the GI system, the intestinal system, and basically these secrete hormones that tell your stomach to digest food, secrete hormones to tell your intestines to move the food along, your pancreas to secrete hormones so that the food can be digested. So it's an interplay between these two groups. So where can neuroendocrine tumors start? Well, this is where variety, I guess, is the spice of life. I think that kind of summarizes the neuroendocrine tumors. And it makes it very interesting to treat these tumors, very dynamic in terms of trying to keep up with recent information on these tumors, because not only can they start in many different endocrine glands, thyroid, parathyroid, adrenal glands in the body. We also have to remember that neuroendocrine cells are scattered throughout many organs, and so therefore they can start in many different organs in the body. So, for example, the lung, pancreas, any part in the intestinal system. So it makes it very dynamic and interesting to treat, but I'm sure as a patient it can feel a bit frustrating at times, because I know many of my patients tell me, you know, I tried to look on the internet, I tried to narrow down what tumor type I have, and it was extremely overwhelming and frustrating and sometimes scary because you end up reading things that are not applicable to you. And that's why it's so great to have the CNET group that sort of focuses on patient education, and I've read through the handout and it's quite fabulous. So. And just to reiterate this point, I just wanted to put up this one slide. So even within just one particular system in the body, so the gastrointestinal system, the digestive system, neuroendocrine tumors are scattered throughout this whole system, and even within that, there's at least 14 types of neuroendocrine cells that have been identified. So very, very varied, and they all have many different functions. So let's do a brief overview in terms of the statistics of neuroendocrine tumors. In general, they're about 0.5% of all cancers. So it is considered a rare tumor, and in contrast to that, breast cancer is about 25% of all cancers. And when you look at it per 100,000 population, it's anywhere around 2.5 to 5 cases diagnosed per year. And once again, to contrast with breast cancer, that's about 100 per 100,000 per year. So in Ottawa, in general, we'd see about 75 to 100 new cases a year. Toronto, just within the Greater Toronto area, would see closer to 200 new cases per year. So, and once again, to contrast that with in Ottawa, we'd see 1,000 new breast cancer patients per year. So it is considered a rare cancer. But the question is it on the rise? Okay, so the number of new neuroendocrine tumors, is it rising, decreasing, or sort of stabilized? And the answer is it's definitely on the rise. So you can see our rare zebra here. trying to get ahead of the group, and it's currently on the rise. The exact reason for that is not known. We think that because with some other cancers, we're doing more screening tests, so we're picking these up by colonoscopies for patients that are being screened for other type of intestinal tumors. Also, in the era of increased imaging and radiology testing, more often patients are getting better imaging tests, so we're picking up things, kind of what we call incidental findings. So here's some data just to kind of prove what I was referring to, and this is the SEER database. So this is a very large database in the United States, the Surveillance and Epidemiology and End Results database. And as you can see, over the last number of decades, every type of neuroendocrine tumor, which is listed here on the right side of the slide, has been on the rise. And more locally, closer to home in Ontario, the Ontario Cancer Registry shows the same trend upward. All right, so with the last few decades. Oops, sorry. Now, the interesting part is how prevalent is this cancer when you start to look at the prevalence. So the prevalence, as you're aware, counts the previously diagnosed cases and also the new cases that are being diagnosed. And actually, surprisingly, it can be more prevalent than some of the other cancer types that the average person would have heard of. So stomach cancer, primary liver cancer, some other types of pancreas cancer, adenocarcinoma of the pancreas, it becomes more prevalent than those particular cancers. So where is it more often to start? About 60% of them start in the digestive system at some level. About 30% can start in the lungs, and then there's a bit of a mismatch in terms of other organ sites where these tumors can start. So the cause of neuroendocrine tumors. This is where we're still scratching our head. It's not known what the cause is. The vast majority of people in this room would not have a genetic hereditary predisposition for this cancer. That type of cause is a very rare cause for neuroendocrine tumors, although we always look for it. And you might have heard of some of those conditions that are hereditary, like MEN1, which is multiple endocrine neoplasia type 1, where the patient can be at risk for a variety of endocrine tumors, but really the exact cause and risk factors are not known. So diagnosis. So sometimes patients become diagnosed with this tumor because of clinical symptoms or syndromes, and this is where we come into the definition of a functioning versus a non-functioning neuroendocrine tumor, of which you're probably familiar with. So a functioning one is a tumor that produces a hormone or a protein that basically gives the patient symptoms. And usually this is related to whatever the original function of that hormone would be. A non-functioning tumor, in general, they do not produce hormones, or they may produce a hormone, but the patient doesn't feel the symptoms from it. So that's one general category, as you're aware of. To point out, still, when you look at the different categories of neuroendocrine tumors, if we split it off into GI neuroendocrine versus pancreatic, still the majority of patients are non-functioning, so they don't have symptoms from their cancer. So 60% in any intestinal neuroendocrine tumor are non-functioning, and 70% if you have a pancreatic neuroendocrine tumor. So we're all familiar with the carcinoid syndrome, and this is how some patients present, and this is where they can get a variety of symptoms, telangiectasias or dilations of blood vessels, flushing, some cardiac disease, although rarer. Some patients can start to have bronchoconstriction or wheezing. Diarrhea is another common presenting factor, abdominal pain, and some rashes and arthritis. So this would be a classic picture of a patient having a flushing episode from a neuroendocrine tumor. But once again, the majority of patients may feel nothing. So just a quick word on the word carcinoid. Even though we still call it a carcinoid syndrome, in terms of the pathology and the diagnosis of this cancer, we're trying to get away from the word carcinoid. And the reason is that historically it was always used to describe a slow-growing tumor of the lung or the GI tract, whereas these days the pathology has really advanced in terms of being able to break down neuroendocrine tumors into more defined categories. So carcinoid doesn't really adequately describe what's going on in terms of this neuroendocrine tumor, so we are trying to get away from using that term. Other presentations of neuroendocrine tumors, so these are CNETS in general, pancreatic neuroendocrine tumors. And basically it comes down to what type of hormone is secreted and whether you get symptoms from it. So a few examples, if your tumor is secreting insulin, as we know, that's the purpose of that is to bring the blood sugar down in the body, and then you might end up being hypoglycemic or low glucose. If glucagon is the issue, you may have a rash. VIPoma hormone, you may have more diarrhea as a symptom. Now, some patients might present where they have no symptoms, and in terms of classic hormone symptoms, and they end up coming to light in terms of their medical condition because of where it's growing. So some examples of that is in the lung, they may present with a cough or coughing up blood, which is hemoptysis. In the swallowing tube, the esophagus or the stomach may be presenting with trouble swallowing or bleeding. The bowel area may end up having pain or changes in bowel movements, or the bowel stopping altogether, which would be a bowel obstruction. So very varied, and that just comes down to the fact that this cancer can start in so many different areas. So let's look at the key things that should come out in terms of the pathology and diagnosis of this particular cancer. Our diagnosis relies on a biopsy or surgical specimen. That's the bottom line in order for us to make treatment decisions. And some of the things we may get from a biopsy are obviously, where did it start? Is this a neuroendocrine cancer? They may do some special stains, so this is where they just stain to see if certain proteins are in the cell or on the cell. And there's some classic ones that are linked to neuroendocrine tumors, chromogranin and synaptophysin. They'll look at differentiation. We'll talk about that in a few minutes. Grade, I'll speak about that in a few minutes as well. And then within a surgical specimen, they comment on lymph nodes, were regional lymph nodes involved, margins, the size of the cancer, were any of the vascular or lymph node highways involved with the cancer, and were any nerves involved. So this could be an example of a path report that we would have returned to our desk, and this is post-right hemicolectomy, so post-removal of the right side of the colon for an appendix neuroendocrine tumor. They tell it's a 3-centimeter, well-differentiated neuroendocrine tumor. T2 is just the thickness that it's going through the bowel wall. When they look at the mitoses, it's 1 per 10 high-power field. Ki-67 is less than 2%. There's some extension into the fat around the appendix. Margins are negative, so in other words, when they look underneath the microscope, they're confident that all the cancer cells that the surgeon could see have been taken out in terms of the microscopic look. No regional lymph nodes. This one here had positive lymphovascular invasion and indeterminate perineural invasion. So the first important part of this whole story is that the pathologist, once the slides are made, actually looks at the cells and tells us that they're neuroendocrine. So by the look of the cells, they're able to say this is a neuroendocrine cell. And in general, they comment on the fact that it's a pyramidal shape, it has some clear cell component to it, and usually it lies along the basement membrane, which is one layer of the wall of an organ. Often they'll start staining for, remember I mentioned synaptophysin and chromogranin, because often a neuroendocrine tumor will be positive for these things. And sometimes they can do additional stains for specific hormones, so insulin, glucagon, and other hormones that may be involved. So I think this is one of the key slides, and this is the proliferation activity of a neuroendocrine tumor. Cells in our body can undergo a resting phase. So some cells are in resting, not dividing. Then they're preparing to divide, and then they're dividing. And so we use this cell cycle to get an indication of within a tumor how many are dividing cells and how many are non-dividing cells. So the first one to comment on is the Ki67, which I'm sure you've probably heard before. This particular protein is present in dividing cells. So they can actually stain the tumor, and it tends to correlate with faster growing tumors the higher it is, and they give us a % on the path report. The mitotic rate is where the pathologists actually look at the cells and they comment, are they in dividing or resting phase? So they can tell by the look of the cells. And they will basically give us a number out of a unit that's a 10 high power field. I think this is an important part because this is the part where patients start to get a bit confused when whatever treatment we decide to treat them with, part of the cancer shrinks, but other parts don't. And this is an up-and-coming, very hot topic. There's a lot of research going on in terms of tumor heterogeneity. So even within one part of your cancer that we biopsy, we can see differences within the various cells. So now one thing that's important is when the pathologists are reporting some of these things to us, like the Ki67, is that they recognize, of which they do, that there is heterogeneity, and they always comment on sort of what they call the hotter spot, so which one would be the higher of the two. So you can imagine this here is a stain for Ki67. If the brown is positive, this could be one part of the tumor that they're looking at, and this could be another part of the cancer they're looking at, and obviously they're going to comment that this one's the higher part, right? And they're going to report that to us. So on the path report, differentiation. So differentiation, you have to remember, is a normal process of our cells, and it's how a less specialized cell becomes more specialized. And the most important part of all of this is at the time of conception, where every cell has to decide what type of cell they want to differentiate into. And so some will become blood cells, some will become muscle cells, et cetera, et cetera. So it is a natural part of our makeup. Now, a cancer also can start to become what we call de-differentiated or more poorly differentiated. So a well-differentiated tumor is one that looks like the parent cell that it came from, and a more poorly differentiated cell starts to move away from that. Okay? And it tends to be linked with the grade of the cancer. So this is where we're moving to, and this is the World Health Organization classification of neuroendocrine tumors, which relies heavily on the pathology. And I think this is one of the key slides because essentially we rely on the pathologists to tell us this is an endocrine tumor. How differentiated is it? So in other words, how much does it look like typical neuroendocrine cells versus it's starting to get more poorly differentiated? Then they'll grade it for us. So they'll grade it as low, intermediate, or high. And the grading correlates with the mitotic count that we just talked about and the Ki67. Okay, so various cutoffs. Now, anytime you choose a cutoff in medical science, there's always going to be debate. What's the ideal cutoff? And it might misclassify some people. But this is sort of more where we're making decisions and basing our knowledge on what kind of cancer we're dealing with. So staging tests. So let's talk about a biomarker just for a minute. So a biomarker essentially is something that we can measure that indicates a disease state. Okay, so is the cancer growing? Do we think there's cancer still in the body? Is the cancer shrinking? And in general, as you can see, we can get these from blood, from urine. We can also get it from staining for the actual cancer itself, from the biopsy. But we need to caution a little bit about biomarkers. They're not the be-all and end-all. Okay, so number one, patient needs to be very compliant in terms of following the test direction, and sometimes the urine samples can be difficult to follow and all the restrictions. There are definitely, for every test, there's things that can cause false positives, so falsely high. Some of the general categories can be diet, medication, other illnesses, okay? And there can definitely be false negatives. So we have to be careful of this. And often with all of these biomarkers, you have to remember that there's a normal amount in our body, and so then we have to define a cutoff where This is normal, this is abnormal, and biology just doesn't happen that way, that it's so cut and dry. So obviously some patients may run a little bit above normal, and that's their norm. Okay, so what are we looking for? So essentially we're looking for slow gradual rises in a biomarker, and also we're looking for it to correlate with what's going on with the scan and what's going on with the patient. So if the biomarker is rising and the patient's feeling fabulous, the pain's going away, they're going off their pain medications, and the scans show that things are getting better, obviously we're going to trust kind of the bottom part of this slide more than the biomarker itself. So you're familiar with these. We do measure in the blood chromogranin. In the urine, we can measure urine for 5-HIA. This is just a byproduct, a breakdown product of the serotonin pathway, which is one of the hormones that can often be secreted in neuroendocrine tumors, and some other ones that are more specific for pheochromocytomas as well. So very, very specific as to which one you're looking at. The staging tests. So as you're aware, many of you have various staging tests, either CT or MRIs. Essentially in the beginning when we order these, we're looking to see has the cancer traveled. This is an example. It's not coming out all that well, but this would be the normal part of the liver. The lighter part, that would be a piece of the cancer that we're looking at. We can also order functional imaging. So functional imaging is mostly done in the nuclear medicine department, and essentially they're injecting a radio-labeled tracer into the vein. Usually this tracer is some kind of hormone that we know can be secreted in neuroendocrine tumors. So those cancer cells take up the hormone, and then also the radioactive tracer is linked to it. So then when you go through the scanner, then we're looking for areas that light up positive. And so that would be an example of the octreotide scan or the MIBG scan. We may order an ultrasound of the heart. Why would we be doing that? So for some patients, they're at risk of what we call carcinoid heart disease. And this is where, in particular, one of the hormones, serotonin, can make breakdown products that can deposit on the heart, mostly on the right side of the heart valves. And over time, that can obviously damage the heart. So sometimes we're ordering an ultrasound to correlate with that. So once we get our pathology done and our imaging done, then we can chat with the patient about the stage. And this, basically, I just want to tell you the general principle is that for any kind of, if the patient undergoes a surgery, the T stage is the thickness stage or the size stage of the cancer. And lymph nodes, or whether there was regional lymph nodes involved in the surgery that they did, and we're looking for distant disease. That's what comes back to the radiology testing. But for every site that it can start in the body, this is an example of an appendix 1, we're going to have a different staging system. So you can imagine we have, 50 that we probably deal with on a regular basis. So I think this is my last slide. So you might hear a little bit about the origin of the neuroendocrine cancer being foregut, midgut, hindgut. And this comes down to the embryological origin, how our body develops in utero. And we're getting away from this a little bit in terms of it becoming a decision factor for patients. We know that sometimes it does impact on prognoses. But in general, you'll see some of the older studies saying that only patients with midgut neuroendocrine tumors, so ones that develop in the small intestine, appendix, proximal large bowel, are allowed on this particular trial. But we're using it a little bit less, using more often what we describe the World Health Organization, where we're using the grading and putting people into a low, intermediate, and high grade category. So to conclude, so NETs are rare, but they are increasing in number. Some patients may have functional tumors, but not all. You're aware of that. Staging is based on the pathology, with grading and differentiation being very important, plus the imaging. Biomarkers are used, but we need to interpret them with caution. They cannot be used in isolation. And the neuroendocrine tumor itself can be very varied and have different clinical behavior. So what does a multidisciplinary team look like? These two look like they're getting along fairly well, even though one's striped, one not. And, but certainly when you're treating a neuroendocrine tumor, you don't do it in isolation. You work a lot with your colleagues, many different disciplines of your colleagues. And certainly it sounds like the CNET group is a big proponent of this as well in terms of their initiatives that they're going through right now. So I think that's my last slide, and then we'll move on, I guess, in terms of the agenda. Thank you.
So I wanted to share with you, I just love listening to our doctors talk about our disease. When I say words, I have to really concentrate. Neuroendocrine, somatostatin, and yet our doctors just, just rolls off the tongue and makes it very interesting to listen to. Thank you, Dr. Goodwin. It was lovely. Our second speaker, Dr. Svetkova, Dr. Svetkova, works with Dr. Maroon, and she will be presenting on his behalf, and so thank you very much. Welcome. Dr. Svetkova has graduated from the Latvian Medical Institute and worked as a radiation oncologist in Latvia. She did her training in internal medicine at the Queen's University, just nearby, then did medical oncology at the University of Ottawa. Since 2013, she is a GI medical oncology fellow, and we thank her for joining us today.
Yes.
Thank you so much for this opportunity to present this topic. And I would start with this picture, Zors. This is a favorite picture of my boss, Dr. Maroon. We used to be taught that as a medical students and in residency, then when you hear hoofbeats, think about horse, not zebra, because we have to make most common diagnosis and less likely to think about infrequent diagnosis. And but neuroendocrine tumors, carcinoids, before it was really infrequent diagnosis, it was zebras in the medical world. But these days it's on the rise. So now it's Zors. Well, and I'm sorry, but a few slides are overlapped with Dr. Goodwin's slides. Probably we use the same materials. So as she told us that neuroendocrine tumors, there are multiple classifications, and one of them is that it's carcinoid tumors and pancreatic neuroendocrine tumors. And either of them could be functioning or not functioning. And it is on the rise, and in the US database, it shows 5-fold increase in the past 30 years. Interestingly, another source that these days it's more than 5 out of 100,000 in 2004 versus a little bit more than 1 for 100,000 in 1973. And this slide you saw in Dr. Goodwin's presentation about incidence of neuroendocrine tumors in Ontario. Okay, well, oops. Well, you can see that about less than 10% of neuroendocrine tumor could originate elsewhere except for bronchopulmonary site and digestive system. And they, functional tumor, secrete vasoactive hormones. And this is serotonin, vasoactive intestinal peptide, gastrin. And the clinical picture is related to these hormones. People could present with vague abdominal pains, cramps, and they are labeled as having irritable bowel disease. Majority of patients, up to 95%, could present with flushing. And symptoms lead to a diagnosis at an early stage when tumor is small and resectable. These hormones production result in carcinoid syndrome, and elevated 5-HIAA level leads to high risk for carcinoid heart disease. Non-functional tumors usually are well differentiated, slowly growing, and as a result, they often are present when disease is in the late stages. It is not associated with production of this vasoactive hormone secretion. Often it is incidental finding during surgery for another reason or on scans that were done for other reasons. These tumors could produce mass effect and symptoms of intermittent intestinal entrapment due to mesenteric fibrosis. Sometimes they could evolve into functional tumors. One of the most important things is monitoring, and it could be done with a blood level of chromogranin A. One of the most important markers for diagnosis is Ki-67. This is marker of cell proliferation, marker of how aggressive this tumor is. It is prognostic factor for survival and marker for biological behavior. There was no well-established, validated cut-off points. So this, you saw this picture, so this is how these tumors look under microscope. And again, survival is associated with tumor grade. Well-differentiated, moderately differentiated tumors, when treated, their 5-year survival is about 60 to 80%. Tumors poor differentiated, so 5-year survival is about 20%. Since these tumors are indolent, they often present with advanced disease. In localized NET, 5-year survival when tumor is completely resected is up to 90%. When regional lymph nodes involved, survival drops to 50-75%. And with distant metastasis, it decreased 5-year survival to 20%, 25-40%. Again, I will not pay much attention on these markers because Dr. Goodwin nicely told us about this. 25-hour urine 5-HIAA, sensitivity is 73%, specificity is 100%. Another marker is chromogranin A, and it could be elevated in up to 100% of patients. Its specificity is 98% and the sensitivity more than 60%. I would like to show this, okay. So before picture, so it correlate between, there is correlation between a level of chromogranin A and tumor burden. It is used to follow up tumor burden, metastasis, and symptoms. And it could indicate tumor activity in cases when imaging shows no disease or stable disease. So this is a very interesting graph. You can see that chromogranin A starts rising a couple years prior to other tests could show progressive disease. We often say we do not treat numbers, we treat people. So should we start treating people earlier when we have chromogranin rising? I don't know. So as Dr. Goodwin presented, tests to diagnose disease, to stage disease, to follow up disease is octreotide scan. And again, constellation of symptoms make this diagnosis difficult. Symptoms are very non-specific, sweating, flushing, diarrhea, vague abdominal pain, bronchoconstriction with wheezing, GI bleeding, cardiac disease. So people are labeled with any diagnosis, but carcinoid, but neuroendocrine tumors. It could be a functional bowel disease, it could be asthma, it could be anxiety, thyrotoxicosis. If a woman is older than age 40, she is suggested to have menopausal symptoms. So these non-specific symptoms could lead to late diagnosis. And it's interesting that it could be 5-7 years prior to having exact diagnosis. When patient had this abdominal pain, or she or he is treated for any kind of inflammatory bowel disease, irritable bowel disease, when nothing helped, the patient is referred to a gastroenterologist. Again, it takes time. It's waiting list for colonoscopy. And eventually, when a patient is referred to surgeon, to medical oncologist, pathologist, there is about 5 to 7 years past. Symptoms that could suggest about carcinoid, about neuroendocrine tumor are, first of all, flushing. It happens in more than 90% of patients. Usually it begins as erythema of the face and neck. It could spread and accompanied with a feeling of warmth. It could persist for minutes or hours. Another sign is wheezing. So if a patient out of blue start having some wheezing, one of differential diagnosis could be a neuroendocrine tumor. Chronic diarrhea, up to 30 loose watery bowel movements a day that could accompany it with vague abdominal pain and cramps. Symptoms of right-sided heart failure. Surgery is the only curative modality. It could be surgery of the primary tumor. It is a mainstay of treatment, and it must be oncological resection. Even in the presence of non-resectable metastasis, it would be helpful to resect primary tumor, and it probably will improve outcome. As well, during the surgery, it is recommended to have prophylactic cholecystectomy to remove gallbladder. When a patient has liver metastasis, surgical intervention could be palliative, so it could be a limited liver resection. As well, this resection could be combined with other modalities, for example, with radiofrequency ablation. When patient has multiple liver metastases that are unresectable, still debulking surgery, as well as other modalities like chemoembolization, RFP, radiofrequency ablation, play a significant role. I will speak about this further in my presentation. Embolization or chemoembolization could reduce symptoms and liver metastasis, and it achieves a chemical response in up to 90% of patients, tumor reduction up to 50%, symptomatic response that could last more than 2 years, and mortality rate is about 7%. There are certain contraindications for this procedure. It's complete portal vein obstruction. If metastatic disease occupies more than 50% of the liver, if there is large tumor, more than 7 centimeters, or sometimes not permissive vascular supply. Complications include gallbladder necrosis, renal failure, pancreatitis, liver abscess. And medical treatment is the most important treatment in metastatic disease. Goals is symptom control, biochemical control, objective tumor control, and improving quality of life. Strategy could differ between functional and non-functional tumors. And alternative management include isotope therapy and the addition of interferon and or chemotherapy. So somatostatin, this is a natural hormone that is produced in our body, and it inhibits production other hormones like growth hormone, insulin, like growth hormone, etc. Its half-life is 3 minutes. We have artificial analog octreotide. Its lifetime is about 1.5 hours. So The mainstay of medical treatment is use of these somatostatin analogs. It relieves symptoms, decreases hormone levels in functional tumors. It is used to prevent carcinoid crisis before, during, or after surgery or embolization. And treatment probably needs to be lifelong. Nothing is for free in this world, so side effects include diarrhea, flatulence, abdominal pain, steatorrhea, nausea, vomiting, hair loss. Often we see symptoms with first injections, but still it could persist and accumulating. Now, somatostatin analogs in asymptomatic carcinoid tumors, hot topic. It could play a significant role in tumor stabilizations or regression, regardless if tumor secretes or does not secrete any hormones. Somatostatin long-acting. It's very convenient once monthly dosing and increase patients' compliance with treatment. We achieve stable somatostatin level in the body. And there is sustained suppression of growth hormone and IGF-1. Okay. Oh, well, then interferon alpha. It is reasonable, the second line treatment. It inhibits protein and hormone production as well as angiogenesis, production of new blood vessels. It is primary medical treatment for low proliferating gastroenteropancreatic tumors. And conventional chemotherapy. We're used to thinking that it's used in low differentiated, poorly differentiated tumors with high Ki-67 level, more than 10%. And usually it's a combination of cisplatin and etoposide, and we achieve a response rate in about 70%. But recently there was presentation on last GI ASCO in January this year. Sorry. Another combination, temozolomide and Xeloda chemotherapy in well-differentiated tumors. It was a phase 2 trial, small trial, 28 patients, and different tumor locations. So some locations include only one patient. So there are a lot of critique of this study, but it's just beginning. So maybe it will be the role of chemotherapy for well-differentiated tumors. So another option is radionucleotide therapy, when radionucleotide is attached to octreotide and binds to somatostatin receptors 2 and 5, and molecule is internalized and delivers radiation energy to cells. A different radionucleotide could be used, and side effects and the response depends on these radionucleotides. It is not available in all centers, only in a few centers of expertise. After diagnosis is made, when a patient is on treatment, one of the most important strategy is to follow up the patient. When we have a symptomatic patient that is stable, follow-up depends on how aggressive disease is. In the second year and subsequent years, it is reasonable to see a patient every 4-6 months. Every time we would like to have a chromogranin A. Often we ask for 24 hours 5-HIAA level as well. Octa scan or MIBG required if we plan surgery, radiation, if there is any changes in treatment suggested. In asymptomatic patient, sometimes we use a watchful tactic, but following a complete resection, follow up every year with annual examination, annual chromogranin A, again, urine 5-HIAA. Well, and if any of these investigations is positive, we need to have CAT scan and or octreotide scan. About 40% of patients could develop carcinoid heart disease. This is associated with serotonin production, and usually it affects right heart. Left heart valves are affected very infrequently. This is affected valves include tricuspid valve and pulmonary valves, and it could be either insufficiency or stenosis. Right ventricular failure is the major cause of mortality in the patients who developed carcinoid heart disease. So on pathology, again, you saw this slide in Dr. Goodwin's presentation. On pathology, you see thickening of these valves due to formation of fibrotic plaques. People who are diagnosed with neuroendocrine tumors, they have echocardiogram, ultrasound of the heart as a baseline, and then if they secrete, if they have 5-HIAA, they need follow-up ultrasound, and they should be considered for octreotide therapy. Cytoreductive surgery is sometimes required to reduce the number of serotonin receptors. If a patient is diagnosed with carcinoid heart disease, he should be followed up by a cardiologist, and often enough, cardiac valve replacement may be required. So in asymptomatic carcinoid tumor, a few years ago we thought that there is no role for octreotide, but somatostatin analogs may have a role and play a role in tumor stabilization or regression, regardless of the secretory or non-secretory nature of the tumor. One of the first trial that support this idea was PROMET trial. This is a placebo-controlled trial that include patients with a low level of Ki-67, level below 2%. Patients had mid-gut neuroendocrine tumors. They were both functional and non-functional, and patients were treated with octreotide and placebo group. Primary endpoint was median time of progression. You can see that in treatment group, time to progression was more than 14 months, more than twice better than in placebo group. There is no significant difference in overall survival, probably because crossover was allowed. It means that patients who were on placebo and progressed, they were treated with octreotide. This slide I found very interesting because results depend, time to progression depends on liver tumor burden. Patients were stratified by below 10% tumor burden in the liver and more than 10% tumor burden. Those ones who had low tumor burden, below 10%, their time to progression of being on treatment was more than 27 months. With a high tumor burden, time to progression on octreotide was a little bit more than 10 months. The same tendency was in placebo group. In low tumor burden, time to progression was 7 months, and in high tumor burden, it was 5 months. This is why we would recommend debulking surgery to decrease tumor burden. So, most favorable treatment outcome is in hepatic tumor load below 10% and resected primary. Benefit of octreotide versus placebo is seen irrespective of functioning or non-functional tumor is elevated or non-elevated chromogranin A is. Another trial that supports previous one is CNETS trial, reported just last fall. This is again placebo-controlled trial of another somatostatin analog, lanreotide. Primary endpoint was progression-free survival. In difference from first trial, there was allowed patients with high Ki-67 up to 10%, and this trial include both intestinal and pancreatic neuroendocrine tumors that are non-functional. Only well-controlled carcinomas were allowed. And again, in overall time to progression-free survival, in placebo group was 18 months versus more than 27 months in lanreotide scan. And again, this trial showed the role of tumor burden in the liver, tumor burden below 25% or more than 25%. And you can see that this is significant difference. In low tumor burden, progression-free survival was not reached. And it was 24 months where hepatic tumor load was more than 25%. So this is a comparison of these two trials that different medications, octreotide and lanreotide. The second trial is larger, and it includes not only mid-gut patients, but also pancreatic patients. The vast majority of patients in CNETS trial had stable disease. First trial in PROMET, it include both functional and non-functional tumors. In CNETS trial, we had only non-functional tumors. First trial had more primary resected disease, 70 versus 40%. So clinical implications of these trials is that use of somatostatin analogs is indicated in asymptomatic patients with progressive disease or with stable disease, but if biomarkers are rising. And we don't know if it is indicated as adjuvant treatment after complete resection of the tumor. Then a few words about pancreatic neuroendocrine tumors. It was interesting trial when sunitinib, Sutent, was used. It was a randomized trial, placebo-controlled, well-differentiated pancreatic neuroendocrine tumor patients were included. And primary endpoint was progression-free survival. And you see that in a Sutent group, it was more than 11 months versus 5.5 months in placebo group. There was 3 RADIANT trials that use another medication, everolimus. It was everolimus group versus placebo group. Another RADIANT trial used everolimus with octreotide versus octreotide and placebo. And again, progression-free survival was better in the combination group, more than 16 months versus 11 months in patients on just octreotide scan. And there are a few ongoing trials like SWOG or 518, where bevacizumab versus interferon, both in combination with octreotide, cooperate everolimus with another somatostatin analog, pasireotide used. So results are pending. So, okay. How multidisciplinary team look like? The same picture. Well, I think it's a little bit different than this one. This is a lot of medical professional. It's radiologist, pathologist, surgeon, medical oncologist, and obviously a lot of nurses. Well, and all of us, we help people to go through this hard journey, through this NET diagnosis and treatment. So, in summary, this is first of all a team job. And the goal is to do diagnosis as early as possible. Surgery, either curative surgery or debulking surgery. Localized treatment like RFA, like chemoembolization, and follow-up. And we need more studies because we have a lot of questions left. Thank you.
So thank you, Dr. Goodwin and Dr. Zvetkova. If you wouldn't mind, we'll do a Q&A now. So if you could, the two of you could come up here, and then if anyone has any questions, you can, we have a mic somewhere. I'll bring that around to anyone who has questions. And also if people online have questions, they can type them in and we'll get them read out. This is the only one? How does this thing come off? Thank you. So maybe we'll put this one here. Sure, you guys. Yeah. Okay. Anyone have any questions?
Thank you. I'm actually asking this question on behalf of a friend of mine who couldn't make it here today. He wants to know if lanreotide is an option because he feels the sandostatin is no longer controlling his carcinoid syndrome.
So I guess you're asking, is there a lot of information about switching over to lanreotide after octreotide?
Yes.
I guess the first question, which obviously can be discussed with who's ever following him, is what dose of octreotide he's on. Have they decreased the frequency of the dose? Often you can bring it down from every 30 days to every 3 weeks. Most of us will sort of push the octreotide dose to about every 3 weeks, 60 milligrams. At that point, they tend to become, you have to inject twice, and so it becomes a bit of a burden in terms of the patient's quality of life because more often they can start to feel symptoms from the injections. The switching over, the tricky part is the access to the drug. Okay, because it's not on, it was mentioned up front, formulary and sort of lobbying people who pay for these drugs about formulary, and it's not paid for up front. So the only way we've been able to access it for a few select patients after trying those other maneuvers essentially is through private insurance. And Calvin, I don't know at your site whether it's the same. Yeah, it's the same.
But would it work?
So there's the potential that it can control. Yeah, yeah, in that setting. Yeah.
I have two questions. The first one's sort of very elementary, and I probably could find the answer on the net, but I'm still a little confused about why we look for the place where the cancer first started and we labeled it. I know how that works, but when I hear about it, I hear that what we're doing then is often surgically removing that starting point. And my curiosity about that is when you know it, when you know where it started, does that end up treating the other places that it's gone? Does it have any impact on, the spreading?
Yeah. So that's a good question. And actually, there's some tumor types where we do have that information. So an example of that is renal cell, where they actually have gone back and even though the patient was stage 4 and it's traveled, they've gone back and taken out the primary tumor. And this is not a neuroendocrine type renal cell or anything like that, and it has shown that they think it improves survival modestly. And they think that it may be some kind of feedback to the metastatic sites, maybe, but they haven't been able to prove that yet. Now, a few things to kind of prerequisite, the answer to that. And number one is we search for the primary because many of the studies included certain groups of patients on those studies. So, for example, the data that's very robust and shows that sunitinib or everolimus works, that's in pancreatic neuroendocrine patients. Okay, so it started in the pancreas and then traveled. So that's why where we're always trying to project ahead about what do we want to use for this patient. It's because in our mind we know what kind of patients were included and what kind of studies and what it has proven for those patients. And also the practical side of it is as well is that often that dictates whether the drug will be covered or not. Okay, so because we know the data from the studies, well, so do the people that fund the drug, right? They look and say, listen, it's been proven in this tumor type, and that's why we okay it. So can I say the second part of your question, where do we know that taking out the primary in neuroendocrine tumors, and Calvin can jump in here and add any additional information. So that data mostly comes from the PROMID study, where they looked back and compared those patients that were on octreotide who had their primary taken out versus not, and they seemed to do better. Now, most of them were GI primaries, so in some place in the intestinal system. And we know that if we do leave it in there, there is a risk that when it progresses, the patient can start to deteriorate because they end up with bowel obstruction. Okay, so, and if you leave it in there too long, your ability to get it out and sort of give them better symptom control from their bowels being obstructed becomes more difficult because it becomes more fibrosed. There's no information from that study or any other study that I know that it starts to feed back to the other parts of the cancer and say, you know, stop growing or that sort of thing. So anything to add there, Calvin? No? Okay, yeah.
So my second question is, when you were talking about, both of you talking about slow moving and fast moving and poorly differentiated and well differentiated, about poorly differentiated and what some of the statistics are on that. I know it's more rare, and you know that's what I've got.
Yes, I know. I know. Yeah.
I just wanted
this lovely gentleman.
to put it. I don't want it to personal diagnosis here, but I just speaking very generally. Can you say a little more about what's being done? I guess generally the way you did about neuroendocrine.
Okay, so first of all, I think the key point of all this is we cannot just take the pathology and say that's what it is, that's the label of the patient, without also monitoring the patient, see how they behave in terms of treatment decisions and what treatments they go on, and sort of get a better indication how this tumor is behaving over time, right? Because even though we may have the best pathologist telling us all the information in the world, it can't trump that what's going on with the patient. Okay, so patient continues to do well, shrinks every time you put them on any kind of cancer therapy, whatever the decision may be. Even though they may be poorly differentiated, then you can't ignore that they're doing well, even though they're poorly differentiated. But in general, if you come back to the beginning, more often poorly differentiated neuroendocrine tumors do present with metastatic disease. Okay, so the first time we meet them, the cancer has already traveled. And that's because the cancer doesn't have to grow really big before it travels. Okay, there's something inherent in that particular cancer type where it travels. And also the other part is that when they do come to light in terms of the medical community, we know that following these patients, we know that the cancer wants to grow quicker than a slower growing one. So we're dealing with probably multiple spots in the body we need to try to control. We're dealing with faster growing. So the vast majority of centers are going to recommend some kind of chemotherapy up front, without a doubt. Now, that doesn't negate, like we said, that then you have to start looking at your patient and saying, okay, some of these other techniques that are reserved for more well-differentiated patients could this patient obtain some benefit from it, okay? There's not a lot of data out there to say whether they would or were not, but starting off with an approach where you're only going to deal with the one aspect, let's say the liver spots, and we know we got spots other place, for a poorly differentiated one, you may end up not doing the best interest in the patient, because then you're not dealing with all the issues in a fast-growing tumor. So those are kind of some of the general principles. Now, in terms of prognosis, okay, in general, we can control this cancer for patients for about a year, okay? In general, getting patients out beyond 2 years can be a bit tough. Okay.
Thank you.
All right.
Thank you. Good answers.
Online questions?
So the first one is, with chemo, radiation, and surgery, can neuroendocrine cancer be cured?
Do you want to take that one, Cal? No, I'm just joking. So it all comes down to site of, yes, so neuroendocrine cancers can be cured. I should say that right up front. Absolutely. Absolutely. There's many, many types that can be cured. But number one, it comes down to pathology in terms of how aggressive is this cancer, the lower grade ones that go on to have a good oncologic surgery, and as Dr. Swetskov said, that's getting the primary cancer out, getting out a good lymph node dissection, making sure you know what stage you're dealing with. We have nothing on the CT scans that are showing any additional cancer. And so some of the examples of that happens on a regular basis are appendix, ones that start in the terminal part of the small bowel. And those patients can go on to have a very, very good prognosis. If you were to throw out numbers, it's anywhere from 70% or higher. It varies for each kind of site where it starts. But so yes, it can be cured. But like I said, it's hard to kind of give a direct answer for that. Yeah.
Thank you.
Oh yeah.
The next one is, if a primary tumor...
Just a second. I would like to clarify that it could be, if it did not spread, it could be cured with surgery alone. And there is no role for radiation or any medical treatment on the top. We do not know if there is any role for octreotide in adjuvant setting. Well, yes. But if cancer is spread, theoretically we can cure it. But I never say patients that I can cure metastatic cancer.
Thank you.
So if on that situation, so if you had surgery and it's been now some time and there's no indication, is surgery alone a sufficient cure, or would it return at some point in time?
So, so thanks for clarifying that, because you're correct. So for our low grade to sometimes intermediate grade neuroendocrine cancers, yes, surgery alone can cure. And there's no data that's showing giving heavy-duty chemo after that will improve the cure rates. In fact, what we know is that for some of those slower growing low grade ones, if let's say we were to meet a different patient where they are metastatic, we're not in that setting where we're doing a surgery trying to attempt for cure, because their tumors are slow growing, they don't respond to chemo. Okay, so it's actually not typically the right thing to do, and typically surgery alone can be the answer. Yeah.
Okay, the next online question. If a primary tumor was in the liver and a bowel resection was done to remove the well-differentiated tumor, however, metastases to the liver occurred, should another biopsy be done of the liver tumors to redetermine staging, or is the original staging applicable?
So this is the question around rebiopsying. So number one, I think everyone is going to say that treats neuroendocrine tumor, that if a patient had a bowel primary that was removed, and we're looking at a few spots on the liver, we're sending them to the liver surgeons for a serious discussion around having the other areas removed. Depending on their original pathology and if we're not dealing with what we think is a highly aggressive tumor. So the data is starting to emerge about rebiopsying patients, and in general, if you think that the patient is starting to move from a less aggressive cancer, of which the original diagnosis was showing you, to a more aggressive, then many people are starting to advocate rebiopsying again, just to make sure that you're dealing with the same differentiation, aggressiveness, Ki-67, all of those factors. But once again, like I said, if there's only a couple of spots on the liver, we're going to be talking about, they're going to be going to the surgeon to have a discussion around surgery, and that's going to be the best biopsy that we can get, right? So.
Okay.
Sorry, and again, it will not be staging. It will be just confirmation of tumor pathology, tumor biology. Because if it is a cancer that that came back, it automatically makes it stage 4.
I often get asked this question, and I don't know the answer, so I'm going to try it here.
No pressure.
A poorly differentiated tumor, is it indicative of the age of the tumor? These are typically slow growing, so do we go from being well differentiated to being less well differentiated to being poorly differentiated? Is that how it works?
So in general, most people start off with you're well or you're poorly differentiated, and you continue along that path. There are, though, a certain percentage of even the well-differentiated that will start to behave more aggressively and become more, either they're more poorly differentiated or their Ki-67, even when they're more well-differentiated, their Ki-67, the more of the cells start to go into dividing phase, okay? So they can have a higher Ki-67. So it's, in general, you sort of stay in that category, but we all know that we look out for that change that can happen. Okay. Calvin, anything else to add?
We're going to give a different spin on it when I talk.
Yeah. Yeah. Okay. It is confusing. You're right, because you can hear of people who it was slow growing and then it was faster growing, and so it's yeah.
When you were talking about the fact that it can be cured, we have been told many times over that it cannot be cured. Is the difference in the fact that maybe we cannot see the scans that we have available here in Canada, that we actually cannot see that there are other tumors within our bodies, and that we're calling it cured here in Canada? And it's not really? And can these microscopic tumors, if they do exist within our body, then grow and then, I don't know how long it would take, but, most of us are told when we're diagnosed that we've had this for 15, 20 years.
Mm-hmm. So just to clarify, you're talking about a setting where they've seen one spot in one area, maybe hypothetically the bowel, they took it out, did the staging, they can't see cancer any place else. Okay.
Correct.
So this is going to have to be kind of a general kind of reflection on that question, because it's hard to say unless you have the exact case in front of you. But in general, that's a principle that we struggle with every cancer, right? Every cancer that we go forward in terms of surgery is that there's right now for most of them, although we're starting to move more into a genetic error where we can start to give a better estimate of what your likelihood of cure is. And in general, all we can rely on is statistics from other patients that have been followed for years. Neuroendocrine tumors are rare tumors. We don't have those statistics that are as robust as, let's say, a general colon cancer that's an adenocarcinoma outside the realm of a neuroendocrine tumor. So, so in general, you're able to give people an estimate of, we think there's around this amount of a chance that you're cured. But can we always tell people, I'm 100% sure you're going to be? No, obviously that's, and this does come down to, well, then what's causing that recurrence? Obviously, the cause of that is 1 or 2, 3 stray cancer cells have got away at some point in that trajectory when the cancer was being developed and have moved off to some other place in the body. They rest dormant for a bit, and then they wake back up and start growing. So, and the trouble is that patients, once they've gone through their surgery, which is a reasonable question to ask, they kind of want to know, am I cured now? But we can't answer that question for most of these cancer types until we follow you for a period of time. And every cancer will be a little bit different, but in general, let's say 5 years, and it really hasn't come back. Then our security to say that, look, it looks good, starts to get more reassuring.
So to follow up from a follow-up question from that would be, so does the doctor, in the neuroendocrine situation, does the doctor then, even though they would say like you're 50% cured or we're sure that it's 90% cured, is there a protocol of follow-up for that patient? Do they still follow up with them on a regular basis?
So there's, so we wish we had excellent studies that followed patients for years to tell you the exact right answer to this question. We don't, okay? So in general, then we rely on guidelines and sort of recommendations from experts sitting around the table saying, listen, what would be reasonable? And there are guidelines that are out there. Dr. Maroon actually was one of the authors on the neuroendocrine guidelines, and there is some directions around follow-up after a surgery with the intention to try to cure a patient. Okay, so because just to clarify, we're still in that situation, right? Mm-hmm. In general, you'll see when you read the guidelines, there's lots of room for flexibility and variability, because that's people don't know. Okay. So you can take a super good-looking tumor, a really small appendix neuroendocrine, all the lymph nodes were negative. Most of us with very, very low proliferation index, most of us are pretty confident that that patient's going to do well. But like I said, you need to follow for a period of time to say 5 years out they did do well. There's some general recommendations. In general, CT scans maybe once a year, the tumor markers every 6 months, but this is all based on guidelines, and there's nobody can say, I know this is the best thing to do. Yeah.
Okay, we have a number of online questions, so if we could just address maybe a couple of more of those, and then we'll break for lunch, and then any other questions we'll get to a little bit later this afternoon. If somebody else has one over here, if we can just hang on, and we'll just get to a couple of the online ones. We don't want them to feel left out. If a pathology report says a well-differentiated NET benign tumor, then can I believe it's not cancer?
So I think we need to get away from the fact that people are trying to call a neuroendocrine tumor not a tumor. Don't you agree, Calvin? It's still a cancer. Depending on the pathology, some are very happy to stay and not travel from where they started, and other ones do want to travel. So I think that they may be referring more to benign, such that they're very. It's looking like a low risk tumor in terms of traveling and becoming metastatic or stage 4, but technically it's still a cancer.
Is liver surgery possible when there are multiple tumors in both lobes, mets from the pancreas, and primary resected?
So that's a surgical question.
Yeah,
so
maybe we'll save that for this
Yeah, we
afternoon.
might defer that this
Okay.
afternoon.
There's another one on debulking, so we'll save that one for this afternoon. Sorry, I'm just reading these as I'm standing here. Another one on debulking. A number of them are surgical. We have someone here with quite a rare neuroendocrine. She had a NET located in her left tonsil and also on the left side of her neck. And she's not able to find out much information concerning these specific type of neuroendocrine cancers. And she's asking if there's a place to obtain more detailed information.
So Calvin, have you guys seen a lot of those types in Sunnybrook? Yeah. Do you mind repeating it there for Calvin?
Sure. The patient has had a NET located in her left tonsil and also on the left side of her neck, and she's not able to find much information about these specific types of neuroendocrine tumors, and wants to know where she might be able to find some information. I think Dr. Isat wants to.
Sure.
Yeah.
So the most typical of neuroendocrine tumors that arise in the neck are paragangliomas, and there is a heritable syndrome that actually results in multiple tumors within the neck repeatedly. So this patient would be advised to go and see somebody who actually knows about the genetics of paragangliomas, and she should be worked up because it is likely heritable and there may potentially be other family members affected as well.
Thank you.
Okay, we have maybe time for a couple more questions. We had some people in the room. I think I saw your hand up a while ago.
Yeah, I just like your opinion on the treatment option of Afinitor versus capecitabine and temozolomide.
Okay.
I'll be covering this a little bit later on, but perhaps
Okay.
Start with that.
We have at least one patient in our clinic under Dr. Goodwin who responds for treatment, at least when I met her a couple of times, yes. Well, but this trial, it's first of all phase 2 trial. It's a very small one, 28 patients, and multiple tumor locations. So some tumor location had one patient. So it's hard to say if it was responding or no. For me, it looks like it's very promising. At least if I have a patient in my clinic who does not have any other options, I will try to start this patient on this regimen.
You would suggest starting that rather than Afinitor?
Yeah, so we don't know. Yeah.
I don't know. I don't know. And then it's again a finding issues because it's easier to get this regimen paid than Afinitor.
Yeah, so there's no information to say which one's better. We've never compared them. The data around Afinitor is larger. More patients went on it, probably a little bit. As you mentioned, the data around capecitabine and temozolomide is smaller patient population, right? So you can always come out with an estimate. Oh, I think there's a 40% chance this will work against your cancer, but that's because it might be that you gave it to a small number of patients, and if you gave it to 1,000 patients, then that answer might be a little bit different. So we don't know which one's better. I think you need to sit down with your main oncologist and kind of chat about both options. Yeah.
Thank you.
More questions in the room?
What's the further distinction between primary and secondary? In particular, a tumor is taken out of a liver and it's suspected to be secondary. What's the basis for that conclusion?
Okay, so primary is, and we don't know where the primary is, and they took it out of the liver. Okay, so in general, I guess in general, what we look at is if it's started in the liver, and we can't find the main place where the first place it was identified, it was in the liver, and then we can't find the main spot where it came from. In general, most people would think that it started from someplace else, okay? And it just, that main area where it started didn't grow very big for us to be able to identify it on any scopes, on any CT scans, on any PET scans, all that issue. Once again, it comes down to all of our data for talking about real prognosis and which studies in terms of treatment included which type of patients. It comes back to usually where did the cancer start, okay? Yours started in the pancreas, yours started in the bowel, yours small bowel neuroendocrine versus a pancreas versus a lung, all of that information. There's some overlap, but it just helps us to sort of, with more security, give you answers around prognosis, about treatment options that may work. That's, I think, why it becomes more important kind of clinically. Yeah. It's not that we're not going to make decisions, obviously, even if we don't know where the primary is. We're going to make decisions. But it just sort of helps to kind of make more firm discussions.
But the actual conclusion that the tumor in the liver was secondary is based on some kind of science, or is just a statistical likelihood?
Yeah, so it's super rare. How many have you guys seen where you think that it's yeah, sure.
A primary is a donor, a secondary is a recipient. We can identify this by looking at the proportion of population of a cancer from a primary that contain stem cells and they're initiating tumor cells. So the higher the proportion of those stem cells, the more likely it is to donate to other sites, so it goes to a liver. Those tumor cells will include those that have a capacity to repopulate in the receiving end in the liver. So that's the definition of a primary and a secondary. And the idea, coming back to what you were asking earlier, is that you want as much as possible to get rid of that site that has as many cancer cells that have the capacity to reinitiate the cancer. You want to get rid of where the highest proportion of stem cells are. That's what you're after. And by definition, that has to be the primary. So you want to get rid of a primary, but it doesn't mean that in the secondary site there won't also be some stem cells. And that's why we all know that you can get rid of a small bowel, but then afterwards the liver has cancer in it, and that cancer doesn't grow back in the small bowel, it continues to grow in the liver. That's because there are repopulating cells in that liver, and that's where we get people like Dr. Law to identify where that highest likelihood of payoff is going to be and target that site.
Well, actually, Dr. Izat, you did touch on what I was going to ask. If you have primary bowel, excuse me, metastatic liver, then liver again, what is the likelihood of the cancer reoccurring again as metastatic cancer in the liver or traveling to a different site? And the other part was, if you have non-functioning, well-differentiated tumors, and you, to the best of your knowledge, you are free and clear right now, but you still experience symptoms around your gut and digestion and everything, is that indicative that there could still be something going on there, you just can't find it? And is it more likely to reoccur again in the liver and not travel to somewhere else?
So there is a likelihood that it's going to reoccur in the liver, okay? But none of us would feel comfortable with just saying, I'm only going to follow you on a CT scan with the liver, okay? There is still the ability for it to travel other places. Although the liver seems to be the tendency in that situation, we're still ordering a CT scan that's of the abdomen, right? Because we know that it may come up some other place. Yeah.
I think as Dr. Goodwin's mentioned, this is the classic approach that we're doing, and this is probably the right thing that we're doing right now. What I think I'm hearing from the rest of the audience, and I think somebody asked earlier, what is it that we're missing? And the truth of the matter is we are missing things. We are missing because of the great uncertainty. And again, Rachel mentioned, we can see two tumors that look exactly the same, and yet one we can image repeatedly for years and nothing happens, and there's another person who doesn't look like they may have anything, and the next scan has got disease that's full of cancer. So it's for this reason that one of the things that we're really trying to identify here is, and it was kind of mentioned a little bit earlier, we need a better way to identify the bad characters. And the way that we've been doing it in the past has been at collections, populations, by doing a CT or an MRI. And that's very grossly inadequate, to be honest with you. What we're really trying to do now is to be able to identify at the molecular level. This is how we've learned from leukemia. We don't wait until somebody comes back with huge to identify leukemia. We look for circulating tumor cells because we know what those markers are. Identify lower bin. And that's really what we need to do here. We need to be able to identify these cancer cell signature, which ones really have characteristics that can allow them to reach different parts of the body in the bloodstream before they reside and before there are masses on. So you've heard what we are doing and what we've been doing for a number of years, which has been great for the largest part, but we haven't been very good at kind of taking the next step to be able to predict and stay ahead of the game. And that's, I think, is where we need to be headed. And there are examples already, as I said, in the so-called liquid leukemias, not in the solid tumors as much. I'll talk a little bit more about this later on anyways.
Okay, we'll take one more question now, and then we're going to break for lunch.
If you have a NET that has been diagnosed and is in multiple locations, and you have a treatment plan that has success with some locations and not others, are you at the stage of knowledge about the relationship between different kinds of chemo and different cancer markers that you can understand which chemotherapy has the best effect on the identified markers of different tumors in different locations?
So we're very grossly categorizing patients into low, intermediate, high, pancreas origin, where it started versus not, and we're testing chemos in that situation. Okay, so for example, you heard about certain targeted agents or chemotherapy. So for example, a lot of the data around everolimus and sunitinib is more in pancreatic cancer patients. Okay. So we're sort of categorizing people like that, but that's not ideal, right? We're not at the point where we can take sort of a molecular profile and sort of look at it and say, wow, this patient is going to do best with everolimus, a targeted oral therapy, versus this patient's going to do better with this type of chemo. We're not there yet. Yeah.
For some tumors, for pancreatic cancer, for example, there was at least a couple pilot trials. Then when scientists tried to identify for which particular chemotherapy this tumor could respond. But this was just pilot trials presented in terms of abstract, nothing more. And again, for neuroendocrine tumors, as much as I know, there are practically three conventional chemotherapy regimens. It's old ones that include streptozotocin, then the most common used for poorly differentiated tumors that behave like small cell cancers. It's cisplatin etoposide, and still prognosis is very poor. And the third one, it was recently presented, temozolomide and Xeloda. So no many options.
Okay, we're going to break for lunch now. I apologize to those online who we were not able to get to your questions, but we'll write them down and try to get to them later this afternoon in the second Q&A. So we'll break for lunch for about 45 minutes, and then we'll regroup.
Hi, everyone. We're going to get started because we don't want to run out of time, and we have a really exciting afternoon for you. We're getting into more information about neuroendocrine tumors and some treatment options. So let's get started. Thank you. I'd like to introduce our next speaker, Dr. Shireen Izzat from Toronto. Dr. Izzat obtained his medical degree from the University of Manitoba, completed his residency training at the University of British Columbia, and his postdoctoral research training in molecular oncology at Cedars-Sinai School of Medicine in Los Angeles. I'm sure there's a few words in here I won't be able to pronounce, so please be ready to smile. He's authored and co-authored more than 250 original research articles and 40 invited review articles, and done more than 150 lectures. He supervises undergraduate medical and graduate students as part of their postdoctoral fellows. He teaches a number of courses including physiology, biochemistry, developmental biology, and endocrinology. Dr. Izzat is also committed to patient care and education. In 1990, he co-founded the Pituitary Network Association and has been the editor-in-chief of the Pituitary Tumour Patient Resource Guide. He's also filled a similar role for the Thyroid Cancer Canada, and of course, our new patient handbook, the Canadian Neuroendocrine Tumour Society. So please welcome Dr. Izzat.
Thank you very much, Pierrette. It's a pleasure being here. And I know that we're supposed to have a Q&A afterwards, but if somebody has a really burning question, I don't mind being interrupted, except for Calvin, of course. He can't. So there were many excellent questions. In fact, I was really very impressed. I've been at this for 25-odd years, and I attend different types of meetings, and I was really very impressed with the quality of questions that many of you asked. You kind of hit the bullseye immediately, and it makes it somewhat easier for me because as I go through my presentation, I'm going to really address two areas that I think are probably high on our minds as both medical professions and as patient community at large. And one of them centers around diagnosis, and the other is on therapy. Those are the two areas that I'm going to cover. And really, I think the diagnosis may seem like it's a very obvious thing to most of you, but as you appreciate later on, there are many nuances that makes it much more complicated. And as technology advances, then we're able to move away from the 1900s and really into the 21st century of being able to identify what type of cancer we're dealing with and how it's really progressing in real time, not in a classical fixed manner, but actually in studying it in a live manner, and how this information is inputted to be able to come up with rational therapeutic approaches. And I'll talk about those that actually are being employed right now. And most importantly, I'm going to emphasize about how they're failing us, how they're really not measuring up to what we think they should have done in the first place. So you already heard about the classical descriptions of neuroendocrine tumors, and it's true, they're all over the place. There's also all sorts of controversies on clinical features, biomarkers, imaging, and different therapies that apply to that. You've seen also this type of slide where there's an increasing incidence of diagnosis. It's actually not an increased incidence, to be honest. It's actually an increase in classification. This is a reflection of how inadequately different tumors in the past were being diagnosed as lung cancer, as small cell lung cancer. And in fact, the biggest reason why you're seeing this lung at the very top is because now we can make a better distinction between small cell lung cancer and neuroendocrine tumors. And we can do this not on the basis of just the presence of the cells, but on the hallmark of all of the proteins that you heard about earlier. So we now, instead of doing one antibody or two antibodies, we're running literally 24 antibodies. So we get a panel that is then examined to be able to say, what is the ancestry of this cell? Where did it come from? What is its hierarchy? Where is it likely to go? This is the kind of information that we need. So we're bringing back the whole organism and distilling it to a level of the DNA of a single cell. And really, that's what this is telling you, is that we are now in a better position to be able to classify what we used to call different cancers. Now we know that they're neuroendocrine cancers. Okay? To my knowledge, there's nothing that we know so far of establishing a particular environmental hazard with an increase in any particular type of cancer, with possible one exception, and it may very well be proton pump inhibitors and certain types of gastronomas. That is an area that actually is worrying me, and it is something that we all do. In fact, sometimes we even paradoxically, we use proton pump inhibitors to inhibit acid production, but in so doing, it actually increases gastrin. And some of you who practice will know that if you image people and you biopsy them over and over again and have been taking proton pump inhibitors for many, many years, you actually start to increase the proliferation of those cells that are trying to fight the effect of that drug. So there's a lot more that I think we're going to learn in terms of what things we are doing right and wrong in terms of understanding why this type of course is taking place. A second myth is that, and I think Rachel mentioned it earlier, the term carcinoid, which I'm really glad that she put it down, because carcinoid is kind of like pregnanoid, somebody who may be pregnant, but we're not quite sure, so let's wait for 9 months. Most women probably would not be satisfied with that diagnosis. I'm not sure what the husbands would have to say about that either. But be it as it may, seriously, it is a cancer. And if anybody ever argues with you, the hallmarks of cancer really are in the genes themselves. And basically, a cancer cell is the one where the authentic nature of the ability of the DNA to recapitulate itself with each generation has become interrupted. That is the most fundamental diagnosis of what we call a neoplasm, a new organism. That is the definition of cancer. It's not something on a CT. It's not something that a pathologist calls. Okay? So at the DNA level, we know that this is the hallmark of cancer. There are no ifs, ands, or buts about it. It's a question of how is this cancer going to behave in the long run, and what can we do with current technology to be able to harness information that can tell us what do we do at this time in a rational manner. And part of a problem has always been, well, let's wait until the patient shows signs of bad disease. And one of them is, let's wait until they're flushing and they're having diarrhea. Well, you and I know that by the time you have flushing and diarrhea, you've got extensive disease that now is filling up more than half of your liver, and we're talking about which half we're going to take out. That's obviously way too radical and totally inappropriate. You've already heard about these cells, and depending on the cell of origin, that's actually how we get to know what that cancer is. But we can turn this around, because now, in order for these cells to actually have their fidelity, for example, this cell here, this is a beta cell. It produces insulin. But now we know what transcription factors. So transcription factors are proteins that bind to the DNA to be able to drive that cell to commit along that pathway. So we call them transcription factors. And in this particular instance, there is PDX1. We can use PDX1 to tell us that is the grandparent of a cell that is pancreatic and insulin in nature. So now if I have a metastasis anywhere in the body, I can take this metastasis, not only say that it's neuroendocrine, I already know it's neuroendocrine, and not only do I want to look whether it's got insulin or not, I may not even find insulin, but I'll be able to tell from its genetic signature using transcription factors, did this come from lung, from pancreas, from ovaries, from thymus? And that way, we're not searching in the classical primary unknown pathway as we practiced medicine 20 years ago, but instead we say the likelihood is that this came from the lung. This patient needs to go for a bronch to find the tumor and identify it, not scanning all over haphazardly. This is something that we're really trying to work on, and I have to tell you there's a lot of advantages to this because it creates a lot of opportunities. And the other thing that you have to remember is that sometimes a person can have more than one cancer. So that just because you have one cancer does not necessarily mean that that's the only cancer that is progressing. And if it is behaving in a highly aberrant fashion, one starts to wonder whether in fact there is some other process going on. And that's where the fidelity of information in the DNA as well as the protein of that cell will tell us, is this the same family or is this another member of another family, a cancer that looks like it, but it's a completely different cancer. Okay. So we're going to skip over these. Then there's, we made some advance in the 1990s, and that was labeling, the Ki67 MIB1. You heard about that. And basically it's a dye that goes and stains inside where the DNA is undergoing replication. The idea being that if a cancer is active in its multiplication, then it should be able to copy its DNA material, and it stains the Ki67. The trouble is, in order to do this, you actually have to have a pathologist who is very attentive to detail. You have to have the proper stain, the proper material, enough cells, count enough cells, and count them over again to make sure that the first time you counted them was not wrong. And it's kind of paradoxical because we learned these lessons 20 years earlier when we were trying to learn about estrogen receptor in breast cancer and HER2 and others. We're now trying to identify the same quality controls that are required to be able to accurately, reliably, and reproducibly predict information in the same way from the lessons that we learned in other cancers such as breast and prostate, applying it here. So take-home message is when you get that number, and especially if you get a really high number, don't sort of take a sigh and say, oh my God, this is the end. There are many pieces to that puzzle that may potentially not be all that bad. At the same time, you'll see the opposite situation where they say there is no Ki67, where that report doesn't have one at all. That's also important information because it means it hasn't really been assessed properly. And it could very well be because the material that was there was insufficient or poorly preserved or not representative. Okay? So don't take that number and sort of go really crazy over it. Another element that was mentioned is invasion. I really like to read about invasion in any tumor specimen. I want to know not only did it extend to the margin of a resection, but what did it do to the adjacent structures? Meaning, where are the other areas where it could have invaded, and did it invade them? And a good pathologist is going to tell you exactly that. They're going to say, it did not invade this, it did not invade this, it did not invade this. In other words, important positives and negatives are absolutely crucial. In its absence, that report is worth nothing. So that information has to be there, and it has to be what we call synoptically reported, meaning all of the fields have to be there, and they have to have an answer. We were making a joke earlier. Whenever there's a square or a bracket in a report, it has to have a value in it. And if that value is not entered, it must mean that there's a technical error. Okay, having said all of that, then the next question is, what are the players that we're trying to look for in that cancer cell? And in at least as of last year, we now know that any cancer has to have these properties. And they're kind of divided into these four major categories. And this is really reflective of a truly cancer cell that is endowed with all of its properties. Okay? So it's able to regulate signals that drive its proliferation, but also it has to be insensitive to factors that inhibit growth. It has to be able to produce enzymes that break through to be able to get into the adjacent structures that I was just talking about. It has to also have the ability to be able to get into a new area and repopulate and reside, meaning its ability to be able to set up new home. That's metastasis. And then limitless replication. This is an absolutely crucial element. That means the ability of that cancer cell to multiply its DNA material like a high Xerox copy machine over and over and over again, and being able to highly reproduce the same defect over and over again. And we now know that specifically in neuroendocrine tumors that there are genes, and we call one of them is the DAX-ATRX. Interestingly, this is a gene that was identified as an impairing pathway in DNA replication first in glioblastomas. And later on, it turned out to be very, very important, as you'll see in a second, in pancreatic neuroendocrine tumors. And we can identify this gene, we can identify its defect, and we can say that, in fact, your pancreatic tumor has the same defect as a brain tumor. And that's probably the patient who will be targeted for temozolomide. Guess what? Temozolomide was first used for the treatment of brain tumors. So many of the stories are now coming in. Similarly, I have to say, going along, this is mTOR, and you're going to hear a lot about mTOR here because mTOR is a survival signal. It's one of those communicators of information from outside the cell, through the cell, and into the nucleus, and most importantly, it's what allows the cell to be able to generate fuel. So you don't want just simply a cancer cell that's able to grow and to be able to replicate in exactly the same unfaithful manner, but also it has to be able to survive and maintain its capacity to survive on very little fuel. And mTOR is one of those fuel suppliers. And that's why when we talk about mTORs, it's basically we're trying to shut off the gas line on that cancer. But you have to remember, the cell is pretty smart. It identifies ways of overcoming that inhibition to be able to overcome the resistance. And then there's sustained angiogenesis. Sustained angiogenesis meaning that not only does the cancer cell want to grow and be able to survive and have a niche and break down all of the material around it, but it also has to sprout new blood vessels. And it's these tiny little blood vessels that are necessary for it to be able to communicate the entry of new cancer cells into the bloodstream to travel elsewhere. And it's that angiogenesis that probably is so important, not only for the survival of that cancer, but also for the new satellites where it's going to be sending them. And that's why there's a lot of interest in drugs that actually inhibit angiogenesis. And that's where the sunitinib comes in, and bevacizumab, we're going to talk about that a little bit more. But remember, all of these elements are essentially they're concerted efforts by a cancer cell not only to grow, but to sustain itself and its daughter cells. And we have to be able to figure out all of these things and how they interconnect so that not only can we interrupt them, but we want to be able to stay ahead of the game to figure out how the cancer cell recognizes how to get around it so that we can stay ahead of that defense mechanism from the cancer cell. So I apologize if this was somewhat complicated, but in a way what I've tried to do is distill about 10 years worth of work into one slide, and in a way it probably doesn't give enough credibility to a lot of the work that's been done, but it is based not on hypothetical models. We now have animal data that have predicted many of these events that we can now validate in a human situation. So this is not all hypothetical. The DNA that I was talking about at the beginning, as you know, all of us have 2 copies of every single chromosome, one from the mother and one from the father. And sometimes that abnormality comes from a mother's side, and we can identify this as what we call the first hit. That means we're genetically predisposed with potential for a cancer. But when we get into one particular tissue, there is another defect that affects the mother's as well as the father's copies of that particular gene. So now we have a double hit. That means that we get cancer not all over, but rather in one particular tissue. However, in some instances, we are born with a defect that comes in a gene that allows us and permits for the development of multiple tumors, not necessarily at the same time, but in different tissues. And that's what was referred to as multiple endocrine neoplasia. One of them happens to be MEN1, but in fact, turns out there are many multiple endocrine neoplasias, including MEN1, 2, 3, and now we know of MEN4. And I'll tell you a little bit more about MEN4 in a second. Bottom line is that we now understand, because one of the questions I always get asked by patients is, why did I get this in the first place? And, you know, the glib answer always is, well, you got a cancer cell that just decided to multiply and grow, as if it's kind of like a little mouse running in a box. But it's really not entirely true. It was destined, to some extent, by a defect that you were born with, and then you acquired another defect, another defect. In other words, there were a series of events that ultimately culminated in this absolute abnormality, most obvious in one particular tissue, and that's why you got cancer in this organ and not elsewhere. It also means that you probably are genetically somewhat imbalanced, we say, meaning that you're probably going to be at risk of other cancers. And that is, I think, is very, very important information, because one of the things that happens to people when they survive a cancer
is they have a potential of getting another cancer. And that's a very, very important area that we have to keep thinking about. So one of the things I always get asked is, well, can we just simply sit from the very beginning and just look at all of the genes, and I'm going to spend this $100,000 and get my entire genome sequenced? Can I do that, Dr. Izad? And I say, absolutely, you can do it, and you'll get this information. So this information is actually still valid. And essentially what it shows is allelic frequency is basically the frequency with which an abnormal gene is present in one copy, either your mother or your father, in the general population. Relative risk is the risk with which the abnormal copy of that gene will result in the disease. So let me give you an example. You now know, for example, that if you have a mutation in a gene called BRCA, you have a high likelihood of getting breast cancer, probably somewhere around 15%. Luckily, BRCA is actually very, very infrequent in the population. Otherwise, all women would have breast cancer. It would be a huge problem. Now, if we look at genes that are much more prevalent in their abnormal forms, they get to be up here. Almost a third of a population will have them. Trouble is, these what we call polymorphisms. These are slight variations, but their effect on increasing cancer is actually relatively modest. So this is the dilemma that we're left with. We've got genes that give us a very big impact, but they're very hard to find. And then we've got genes that have very small effect, but are too prevalent. And probably somewhere in between, we're trying to come up with a harmonious approach, identifying the very infrequent, the very common, and all those in between. And we can do this on blood on a patient. Okay? And we have a study actually going on at UHN where basically that's exactly what we do. We get patients coming in and we genome screen them. We identify the different mutations. And the trouble is, it turns out that the average patient with a solid cancer doesn't have one mutation or two mutations or 10 or 30 or 40 or 50, but on average somewhere between 300 to 400 mutations. So, for those drug companies that tell you, oh, we have a drug for your cancer, I say, oh, you've got a drug that identifies and recognizes 400 different mutations. Thank you. Can you tell me what it is? They leave the room very quickly when I say that. So I'm not very popular. But just want to remind you that this is one of the things that you will always get asked. And when you say, all right, what can I do from my end? How can I really help everything in whatever way I can? And one of the things that we ask is to always consider participating in research studies where very small materials, very, very tiny materials are actually collected, and it doesn't really affect you in any way because this is the information that we can get. We can then plot it, and basically we can look at literally hundreds of thousands of genes, and we can see classifications, for example, of the small bowel versus pancreatic. And you can see that the many genes that I was telling you about are completely different in these two different types of cancers. And this is another example that you can actually look at pancreatic neuroendocrine tumors and divide those that are relatively benign from the more malignant ones. Same organ, same grade, same G. Same G1, WHO 2010 classification, but completely different genes that are affected. And that's going to be, the bottom line is, then we're going to have to be able to analyze. So in this particular study, 71 genes distinguished the benign from the malignant ones. That just simply means that we're going to have to tailor a drug approach that takes into account that many genes, at least. So it's not very easy, but it is potentially doable. This just slide of one of the more important studies, not from our group, but from another group, that basically shows that if you take a pancreatic neuroendocrine tumor and pancreatic adenocarcinoma, the genes that are affected are completely different. And this is the one that I was telling you about. ATRX, DAX, and MEN1 are present. Notice mTOR itself is actually mutated in about 15% of pancreatic neuroendocrine tumors, whereas mTOR is far more mutated in poorly differentiated adenocarcinomas, meaning mTOR inhibition is likely to work much better there than it does in PNETs. And then, of course, you can see that we've got other genes here that we have no idea how we can target. All of this just gave us hope. Remember, this just came about in 2008, so this is all still fairly recent stuff. The advantage to DAX, and I'm really very interested because somebody in the audience here asked, okay, if I'm going to go on temozolomide, if you ask the average medical endocrinologist what's the target for temozolomide, they say MGMT. And that's probably the right answer for an exam, but really it's the wrong biological answer because MGMT, it just happens to be a gene that is methylated, and when you use a methylation inhibitor, and it's affected, but it's not the mediator. The actual target in brain tumors and in pancreatic neuroendocrine tumors is actually DAX-ATRX. And we can tell that you have that mutation because we can stain for it, and what this slide is showing you is the blood vessels stain for ATRX, because the blood vessels are not affected, whereas the tumor cells, and this is a pancreatic neuroendocrine tumor, it is lost. Then we can say, this patient, instead of going through 4 or 5 different drugs and then come back and use temozolomide, you say, this patient is far more likely to respond or should be tried on temozolomide to begin with. Cuts to the chase, deals with things in a much more practical manner, because remember, and we talked about this earlier, the reality is that for us to not only use drugs that are very expensive, but to use them in a sequence where we try them first, and if it doesn't work, then we go to the next and go to the next, is not always very easy, and many insurance providers will refuse. For example, even though we have mTOR inhibitor, Afinitor and Sutent both approved, if you get one, and you get approved for one, if you decide that you're not happy with it or you get side effects, switching to the other becomes really very difficult. So we have to really keep those realities in mind. This particular slide I'm just showing for a very important reason, because this came from our institution about a year ago, and essentially it identified the gene responsible for intestinal neuroendocrine tumors, which is something that's eluded identification for many years. It turns out to be a gene called P27, which is involved in regulating the cell cycle control in the nucleus. The good news about P27 is it gets degraded. It gets degraded very quickly, and we know that if you allow for it to reaccumulate, you can actually affect the cells in a very profound way. And we know a drug actually used particularly for multiple myeloma called Velcade. It's a proteasome inhibitor and restores P27. So here we have an opportunity now to look at a drug that's been used for a completely different cancer, bring it to the field based on the genetics identified very recently. And that's probably the reason why many of the mTOR inhibitors really do not work nearly as well in intestinal neuroendocrines as well as they do for pancreatic disease. Okay. You're still all right with me? Yes? We're good? Okay. Calvin is still awake, then I'm in good shape. So therapeutic options. The first one, obviously, is I'm always hopeful, and everybody says the same thing, essentially, is if you can find a tumor, can you get rid of it, and can you get rid of it entirely? And that's where fantastic surgeons like Dr. Law really can never really be replaced. They always have a job, because if you can get rid of all of the cancer. The trouble is, and everybody talks about curative intent. We don't talk about curative intent, meaning gross total removal. Everything that he can see based on the imaging that was provided to him before the operation and in the operation. And he's going to talk about the details, so I'm not going to pretend to be a surgeon. However, at times, the surgeons also will enlist the help of interventional radiologists, and they will get one of them to come in and maybe consider zapping with ultrasound radiofrequency ablation parts of the liver that are not technically amenable to surgical resection, or maybe even embolization. And it's something that I really like to see more and more, that collaboration between the interventional radiologist and the surgeons at the tumor board in planning the operation to begin with. Very, very important. And then we talk about medical therapies, and then later on you're going to be hearing from Dr. Beauregard about radioactive therapy, so I won't dwell on this. But medical therapies I want to spend a couple of minutes on, because many of you asked some very important questions. And really the factors that depend on this is, to some extent you already heard, is the type of tumor, but I want to emphasize that there's been an overwhelming emphasis on grade of a disease. And one of the things that I don't like very much sometimes is that a patient will come, they've got diffuse disease, they've got liver metastases, the needle gets in, they get a few cells, and it's called a G2, for example, or maybe even a high G2. And then everybody says, well, you know, this is really very bad, maybe we should put this patient on chemo and just try it. Or maybe worse yet, let's say it's a G3. to make it much more obvious. And my point is that, and I think this was mentioned earlier, that grade alone is not sufficient. Grade provides some information, but the behavior is probably articulated more by the combination of grade as well as stage of disease. They provide complementary information. And to some extent, that's what the extent of liver involvement comes back. I think when you heard about the PROMID study, that's what the PROMID was telling you about the extent of liver involvement. It was telling you not so much the grading. It had nothing to do with grading. It had to do with the evidence that the extent of disease, and that's extent of involvement, is reflected by the stage. And we have very good staging methods now based on the imaging and techniques that we have that are really very good. We used to think that functional versus non-functional were really very different, but I don't think that this is true anymore. Even though I have a background in endocrinology and I measure all sorts of peptides, I have to tell you that for the vast majority of patients, the hormone production is not really crucial in terms of the ultimate therapy that we give them, with some exceptions, like those that are producing an excess of insulin, for example, where we have to shut it down very quickly and we have to use some specific drugs for that purpose. One of the things that I'm much more interested in is patient performance status. One of the things that we often do is we often wait and wait and wait and wait until a patient's disease has progressed. And that's when we say, well, it's really very obvious. It's kind of like the woman that is about to go to birth and deliver, and we say, yeah, we now are sure that she's pregnant. So we better do something about it. And that's probably true if you want to be 100% right. But hopefully we can try and do something a little bit about it earlier. And that's what worries me, is that many of our patients get to a point where their performance status, their ability to be able to function on a day-to-day basis, is affected. That is absolutely crucial. And the ability of us to intervene earlier when performance status is still preserved is critical. We now know, actually from a number of studies, that the performance status also influences the ultimate outcome, despite the type of therapy that we think is actually causing it, indicating that the whole being, so even though we're talking about cells and DNA, I don't want to forget about the whole being, and that's absolutely crucial. Of course, availability is very important of the different therapies. So just so you know, staging has evolved over time, and the 7th edition from UICC, which is the International Organization of Cancer Control, it gives us different methods. These are just slides to show you. I wanted to show you this particular slide for the reason being that these were almost 100 patients from our center of intestinal neuroendocrine tumors. And essentially, if you were to look by WHO alone, or you looked at AGCC staging and you looked at progression, overall survival, and death, you can see that the grading really was not terribly helpful. That the overall survival was still very much affected, and ultimately death related to disease was affected by stage. Meaning that grading and staging provide complementary information, and most importantly, make sure that the grading is based on the most current of all editions, as well as the staging itself. Okay, all of this you can find a little bit in my bigger presentation. Pharmacologic approaches. So this is something I get asked all the time. So here we have these drugs. You can see that these are the somatostatin receptors. They activate a certain pathway, information from outside the cell, through the cell, and ultimately to the nucleus. These are the angiogenic, and these are actual receptors that are present not on the cancer cell, but they're actually present on the pericyte. The pericyte is a small little endothelium. That's the small blood vessel that runs adjacent to the cancer cell. So now we're not talking about the tumor itself. We're talking about the tumor microenvironment. This is a very important issue because sometimes when we're getting tissue and we're getting biopsies, we're only getting about the epithelium of a tumor. We're not studying the tumor stroma. The tumor stroma, the supporting matrix, that environment of the entire cancer, comes out only when Dr. Law pulls out the whole tumor. And that's why surgical pathology information, and especially high-quality samples that are processed properly and interpreted properly, provide a lot more information than a single biopsy that's been done on only a few epithelial cells. Very important to appreciate that there are many components to the system, and it's not just the tumor epithelium. A question that was raised earlier, switching from octreotide to lanreotide. So it turns out somatostatin receptors, there are in fact 5 different receptors. And octreotide and lanreotide basically bind to 2 of the 5. So if your tumor happens to have one of those 2, and predominantly SSTR2, you're in good luck. The two drugs, as far as I'm concerned, are Pepsi and Coke. Okay? Take your pick. One is a little bit easier to inject compared to the other, but really there isn't anything compound-wise that's different. The different molecule is pasireotide, which is able to bind all 5 somatostatin receptors. But in so doing, you may think, okay, it hits all 5 somatostatin receptors, must be better. Trouble is, it produces a lot of side effects because now it's inhibiting your insulin, it's inhibiting your blood flow to the kidneys, so you pay a price for that. PGF receptor is a platelet-derived growth factor receptor, so that's what I said is in the blood vessels and in the endothelium. And this is where Sutent is supposed to also inhibit, is this pathway, and everolimus over here, and here's somatostatin. So kind of makes sense. It makes it look relatively simple and straightforward. But if you actually look at the different studies and you look at the outcomes, and I just put the numbers here in terms of progression-free survival, bottom line is it's always in months. And even when you mix and match, it's almost always in months. And when I show you even the bigger studies, this is supposed to be fancy, but one of the better studies cost millions and millions of dollars. Okay, everolimus, Afinitor, and this was in pancreatic neuroendocrine tumors. I want you to pay attention to these lines because these are the lines that either make it or break it. First thing you want to look at is there's a p-value, and if it's less than 0.05, it's really significant. Okay, that's great. The next thing that you want to look at is what's the hazard ratio. Hazard ratio is what is the ratio of the disease progressing if you took the drug as compared to if you took the placebo. And if it's a hazard, you want that hazard to be low. You don't want it to be high. This is one situation where numbers, you want them to be low. You want to reduce your hazard. So when you get a hazard ratio of 0.35, that's actually pretty good. However, it's like a sale, meaning it's of a limited time. Hazard ratios are calculated only for the beginning and defined periods with a beginning and an end. And then you ask yourself, what happens after that? Nobody knows. What happens if you challenge a patient? Nobody knows. What happens if you stop the drug? Is the disease going to get worse as compared to it was before? Nobody knows. So I'm not trying to be a pessimist. All I'm trying to do is show you that what we have here, and this is supposed to be state-of-the-art, works in slowing down the disease as measured by structural studies that we call CT and MRI, and we give specific measurements, and we create those thresholds, and what we call the RECIST criteria, if you will. But really, it doesn't cure the disease. And it gives us a limited opportunity. And that's why one of the questions that always get asked is, should I go on this drug now? Well, remember, this is a sale for a limited time only. So use it wisely. And the question is, do you have the right disease and do you have the right time to be doing it? Those are the important questions. Here's a different one, everolimus and placebo and pancreatic neuroendocrine. Again, just so you can see, these are what we call waterfall plots, and this is what happens in every individual patient. These are the ones that took the drug versus those with the placebo. Interestingly, those receiving placebo, there were a few purple ones where the tumors actually went down with placebo, just attending the study, probably going to a treatment center and just being... and of course, you can see also the opposite. Here is everolimus, where actually they took the drug and the tumors got bigger. So always, whenever you're looking at numbers, you want to, like signing a contract or you're buying insurance, look at the fine print and try and read as much as you can so you understand. And then the next question you have to ask is, how is my tumor going to learn to escape from this inhibition? What is the feedback loop? How long does a tumor take to learn this escape mechanism? And can I do something about it? And it's for this reason, and believe me, every single drug that we know of that inhibits anything very quickly learns to get around it. And that's not really surprising. I mean, we knew that a century ago when people took antibiotics and developed resistance. Bacteria, even bacteria, not mammalian cells, but bacteria were able to learn to be able to develop resistance. That's a very common thing. That's a biological principle. So that's why people started looking at combination therapies. Combination therapies are exactly for that. It's not so much that one drug is better than the other. It's that combination therapy is supposed to provide synergy by interrupting one pathway as well as the other pathway that the cancer cell uses to escape from that inhibition. Okay? That's the main principle. So one of them we knew about was, okay, we are inhibiting mTOR. And one of the things that happens with mTOR is that there are many other genes downstream of it that when the cell senses they're being inhibited, it starts to activate upstream and produces more growth signals. So giving octreotide to inhibit the growth signals would be of added value. And that's why we talk about combinations of octreotide and Afinitor as potential synergy. And that's essentially what's shown here, everolimus and LAR. And indeed, in intestinal nets, you can see that there is a benefit. Here in the blue is everolimus alone, everolimus and octreotide, sorry, and in red is placebo and octreotide. You can see hazard ratio, but it's not 0.3 anymore. It's 0.77. It's not much of a sale. There's a p-value, 0.026. This was a reasonable study, and you can see the number of patients at different time points. Yes, the sale is almost over. This is the last study, and I wanted to bring this up because it received a lot of recent attention. That's the CAPTEM. It was from New York, and essentially it's a combination of temozolomide Temodor, which is an oral agent that is given. As I said, this is the one that's used for brain tumors, as well as capecitabine. And really, capecitabine is the oral form of a drug we used to give in the past 5-FU for gastrointestinal cancer. Basically, it gets in and inhibits DNA multiplication. So the problem is that temozolomide does work, and temozolomide and capecitabine work well in relatively small studies. As you can see here, this is one example from JCO. Where you can see essentially that the disease is stable in the at least half of patients, but at a price. We're now getting into higher toxicities of treatment-related toxicities to the point where half of patients get into trouble eventually. And this is one of the biggest issues, especially when you get into combination therapies, is that you're getting now into drugs that have overlapping benefits, potentially, but also overlapping toxicities. So we're not there yet, and this is just an even better study, bevacizumab. This is a monoclonal antibody that recognizes the VEGF angiogenic pathway and octreotide. This was just published last month, and it's actually a reasonable study because it included moderately differentiated, not just the well-differentiated, but moderately differentiated. These are patients that failed everything, including mTOR inhibitors. And you can see here that actually half of patients showed a resist response, which is not bad. So I'm going to end here by showing sort of a quintessential design that typically we say, all right, get the diagnosis, get the right operation, debulk and remove as much as you can, get the grading, get the staging, and then you'll go into mild, moderate, or severe disease with either biotherapy, chemotherapy, or really highly toxic chemotherapy, as has been mentioned before. But I think down here is the area of targeted radiotherapy, which Dr. Beauregard is going to talk about. My prediction is that in the next 5 years, radiotherapy is going to come way up here, because what we're going to be doing is we're going to be giving everybody radiotherapy to kill those cancer cells that Dr. Law was not able to get at or could not see. And in so doing, we can give far less radiation. We can do it in a manner that we've done for years in treating another kind of cancer, and that is thyroid cancer. And the survival from thyroid cancer has been excellent with radioactive iodine because everybody that we knew when they had surgery, we knew that we left remnants behind. We gave them targeted therapy in the form of radioiodine, and it worked. And yes, I do agree that there is the need for not only team effort, but to be honest, the really main reason why you want to have a team effort is because we argue a lot with each other. And that's how we get to challenge each other, and that's how we get to learn from each other so that hopefully we can intelligently translate this to you. Thank you very much for your attention.
I'm really glad I didn't have to give that presentation because I'd still be pronouncing some of those first words that Dr. Izat was using. Quite a challenge, but thank you very much, very informative. And now we're going to go on to surgery. So I'd like to introduce our next speaker, Dr. Calvin Law. He is the chief, Edmonton Odette Cancer Centre in Sunnybrook in Toronto, and the regional vice president of the Cancer Care Ontario. Dr. Law completed his medical school training at the University of Toronto and his general surgery training at McMaster University. He has settled at the University of Toronto and at Sunnybrook. He has served many roles, including being national chair for several Canadian cancer groups, co-founder and director of the Susan Leslie Clinic for Neuroendocrine Tumours, a member of the program in evidence-based care for gastrointestinal oncology at Cancer Care Ontario, and as an examiner for the Royal College of Physicians and Surgeons of Canada. So let's welcome Dr. Law.
Thanks. I was thinking, after lunch I should make the smart guy go first, and then I realized that I'm in the horrible position of preventing you from getting to your second coffee. So anyways, on that note, I'd like to maybe go over some of the principles of surgery, and it hopefully meshes well with everything else, and I'm going to try it with a little toy because that's what I like. So let's see what happens. Excellent. So what I'm going to do is take you through some of the aspects of surgery for neuroendocrine tumor, and what I really want to do is take you from one end to the other, because that's what I do. That's my glamorous life here as a GI surgeon. But as we do this, I'll go over the broad aspects of surgery as well. All right. So I think you've heard surgeons love being the center of attention, and we love being considered what we call the primary modality of cure. But I think as you go through this talk, I hope what you also hear is that we're also a primary modality of control, and I think that's an important word to know. And the second thing is, outside of primary, I do want to repeat this word over and over again, because the important thing about your outcome is not to find the Lone Ranger, but to find a surgeon that's part and integrated into a team. Now, oops, we're going the wrong direction. That's what I get for playing with a new toy. So the first one, after you eat your food, and it's hopefully still sitting there right now, and not coming out soon, is the stomach neuroendocrine tumors. And I know I don't want to repeat a lot of the things that Dr. Izat said already, but what's really interesting is, and what makes it difficult for surgeons, is to understand that we have to try and listen to Dr. Izat and get as smart as him, but we have to actually understand these types. So I'm going to take you through them and show you why that's important. So the first type is of gastric neuroendocrine tumor is very funny. It is this thing called type 1. It is very small, and unfortunately now that many more of you are engaged in this whole thing about screening and colonoscopies, and sometimes you're wondering if you're really getting a deal or whether the guy's just putting scopes in both ends. You get both ends done at the same time. Fortunately, there's something called anesthetic, and you only remember a little bit of it. These things are getting discovered more and more. But I think what's really important with these is these behave very well. They hardly ever give you trouble. But if I was a patient and I didn't know this, and somebody said, well, I found this tumor in your stomach, the first thing that goes through your head is, oh my God, let's look up stomach cancer. And then if you Google stomach cancer, you might as well just lie down on the floor now. Because stomach cancer is totally not neuroendocrine tumor, and you're going to get a whole bunch of wrong information. Now, for the surgeons, what's important is the only way you can tell truly that it's type 1 is you've got to give the pathologist more information than just taking out that little tumor that you see right here. You've got to give him some of the normal, or what you think is normal tissue here, because what makes type 1 is the fact that the surrounding stomach is irritated, and Dr. Izat talked a little bit about that in terms of those proton pump inhibitors. Now, type 2 he spent a long time talking about as well, because these are the ones associated with an MEN or a multiple endocrine neoplasia. I think the main thing here is that for surgeons, they need to know these are a little bit different, and you need to suspect it. And sometimes I need Shereen's help to figure out whether this patient has that syndrome. And then there is the type 3. Now, the type 3 sometimes can look like they're a little small. They're usually more aggressive. But how do we tell? We tell not because it says neuroendocrine tumor here where you scope, but because the normal tissue here does not have the same characteristics, as what you saw in type 1. Type 1 is a reaction to that atrophic gastritis or that irritation in your stomach. Here you got a tumor growing where there is no irritation in the stomach, and that involves a different kind of surgery. That surgery is bigger, that surgery is more aggressive, and it'll help you, but you've got to choose the right one. I certainly would not want my stomach out if that's what the issue was. And then there's a type 4. And these are usually more aggressive tumors. You can see this. I know you just had lunch. Okay, I'll minimize the amount of gross pictures. But anyways, this issue is that, again, you got to get a good biopsy from there. You need to know what it is, and this is important here. Remember, you guys were talking about high grade, low grade, and things. But on the other hand, in this case, it is important. This is not a situation for a surgeon to rush in with the sword, so to say. But it is an important situation to go back to your team, because if this is truly this high grade kind of gastric neuroendocrine tumor, you may get more bang for your buck with systemic therapy. So it's really important to tell the subtypes. And you know, for a surgeon, I don't know. It's hopefully when the surgeon comes up and is talking to you about your gastric neuroendocrine, this table comes up sort of like the Terminator, where you have to choose different choices of what to say. So yeah, but there's no swear words in this one. So hopefully you choose the right thing. And then here, I've already talked about a lot of those characteristics. We have to match them up with the right kind of surgeries. And also important to many of our patients today is the fact that you have to now match up who you do surgery on with the type of surgery that you do. So these are really important. I'm not going to get into all of it, but let me just show you something. This is your typical stomach, okay? So this is, you do something, you eat, you burp here, you do all sorts of cool things. But one thing you need to know is that normally this end of your stomach is what creates the signal for you to make acid, and this end of your stomach makes the acid. But this, if you take proton pump inhibitors, this part starts overproducing and creates this irritation here, and then every once in a while you form these little neuroendocrine tumors. Now, if you have an MEN, like a type 2, and your surgeon goes, don't worry, I can help you, I will just take out this part of your stomach, well, the problem with MEN is you still have that kind of gastrin tissue in other locations, and so you ended up with a surgery that continues to create neuroendocrine tumors. So don't do that. And it's why it's really important to understand the subtypes. There's no way today that I can go over all of those, but I think what I want to tell you is surgery for neuroendocrine tumor is not cut along the dotted lines from A to B. It's really important to get it right, to choose the right surgery, and there's no way nowadays, with the way medicine is blowing up, for any of us to know all of this, which is why you need a team. And the team includes everyone and a pathologist who the patients never meet, but is such an important part of your team to help us understand how to plan your therapy. The next one is the small bowel, and in fact, this is one of the most common. Jackie, you were saying that you had undergone this as well, and I think the issue here is that a lot of times people have had old scans. This is a really old scan, and it's very non-specific. It looks like a lot of things. It looks like endometriosis. It looks like inflammatory bowel disease. It can look like Crohn's. It can look like a lot of things. Well, what's important is it also knows how to hide. This is a standard CT scan. And what's really cool about this CT scan is, other than the fact that it's good, is that you drank that awful stuff that you think they only make people they don't like drink. And that's the stuff in here. It's a contrast drink that's why they call you into the CT scan at least an hour ahead and you start drinking this stuff. Well, the issue is that if you're looking for a small bowel neuroendocrine tumor, this stuff actually, this white stuff here, it helps a radiologist see where the bowel is, but it actually hides the problem. And one of my patients had this scan done, and we suspected something was going on in there, and we did a different kind of scan called an enterogram. Now watch what happens. In enterogram, we make you drink equally horrible stuff, but it doesn't turn white. It's the stuff you drink before your colonoscopy, and just in case you thought, I'll never drink that again, then we scan you and we make you drink it again, but there you go. It is, what's different about it? It's called negative contrast. It's not white. And we have to time it with an injection they give you. You never know what that is. It's not from the CA. It's actually helping this. And it lights up your arteries. And the neat part of these tumors is that they show up like light bulbs in these locations. And we found 11 more tumors. Now, what I was trying to show you here was that's where her original surgery was done. That's all the original surgeon could find. He closed. These are staples that you use to put the bowel back together. And there we had to go and operate again and remove the remaining 11 tumors out. So these are kind of things that if you don't do the right tests, you're not going to find. So why am I telling you this? Because again, surgery is more than one cycle of stainless steel. You know, I try to be a medical oncologist, so that's what I say. But it is indeed a team effort, and if you don't have a good GPS or a map, there is no way you're going to get there. So small bowel, about 30% of them have all these little lesions here. They're often multiple. So it really, you know, not only do you have to have good imaging to get you an idea of what you're doing, you've got to look for it at the time of the operation. So that's important. The other thing is that they do spread to the lymph nodes, and this is really tricky for surgeons to know what the right thing to do is. So here's a this is a nice lady, and I'll tell you this, the ending of the story is good. She came in on her 80th birthday with a bowel obstruction here, and she's 91 today, so that's the good news. Now, the problem was that initially you have to decide what operation you're going to do. You see this tumor, it's blocking the bowel, you're in the middle, you're taking it. If we did this, we did a little surgery, so let's try not to hurt her, let's do a little surgery. The problem is you're leaving all these lymph nodes behind, and they can continue to grow, they can continue to give you trouble, and one of the problems with neuroendocrine tumor is they can cause scarring and they pull things in. Okay, so let's go Rambo style. Let's go take a whole bunch of bowel out. Then now your problem is, you know, that lunch you had is out in Lake Ontario within, you know, about 25 minutes. So that's not very good. It's a horrible quality of life, and you can't do that either, right? So it's like, so what do? Well, you got to know what your partners can do. So the other way is to take out enough nodes, and maybe there's one, I mean, I just left this one here. Maybe there's one that would threaten the length of your bowel, and you know, instead of going totally charging into it, if it's not going to come out, then at least try to maintain that bowel length, and then go get Rachel, and go get Shireen, and go get Matthew, and everybody else to help us, you, most importantly, to deal with this later with the other things and the other treatment options that we talked about. So this is a real trick with small bowel because of its location and its relationship to the nodes in the blood supply of the bowel. The next one, of course, is appendix. We see tons of these because we take out lots of people's appendix, and in fact, we may have even seen more before because when you had a C-section or removal of ovarian cyst or something, they used to take out your appendixes all the time. And with the appendix, fortunately, most of them are in this criteria, which is just treated with an appendectomy alone. I know that a lot of times people get, now that neuroendocrine is more known about, people are told you had an appendiceal carcinoid tumor is what usually called, and people get worried. But there are criteria, and fortunately, it's not that many people where a large tumor with potentially lymph nodes involved need a huge amount of surgery. Then there's this gray zone in between, and again, how do you determine surgery for the gray zone? It's not so much the surgeon comes in and kind of looks at you like, yeah, you look good for surgery. It's actually all the predictions of whether you'll need the surgery or not are hidden in the pathology report, so that's why you need a good pathologist to get you through that. Yeah, okay, so all the guys are cringing. So the rectal nets, now you're going to see more than ever because everybody's getting their screening colonoscopies, and what we do is, you'll see this picture. This is what we do at the end of a colonoscopy. It's usually when the drugs are working best, and the reason you see this scope here is because we've turned the scope like a J, and we're looking at ourselves. So that we have to do because as we pull out, this is the part that we miss, and oftentimes right here at the end, this is the way out. This is to Lake Ontario, right? Okay. So when we pull out, sometimes we see these. And here, I mean, the good news is most of them are small. And the small ones really don't do anything terrible. You need to keep an eye on it. And sometimes you can just remove it with the scope. Beyond the scope, you can remove it with a slightly fancier kind of scope that takes an anesthetic. And you can remove a deeper level. But again, for the small ones, the big message here is that we can, in fact, tattoo you. You cannot choose styles, butterflies and roses, etc., but you can get a big ugly blue spot put there that nobody else will see, except what's important is the next time you have a scope, somebody can find it, recheck the area, or even if it looks normal, we can rebiopsy the area again and see if there's residual neuroendocrine cells. So these are little things that need to be done. There are people with larger neuroendocrine tumors, and those in the rectum need to be treated like colon cancer, and you need to have a standard resection. All right. So I think I've gotten from your mouth and right through to Lake Ontario, and then the next scary part is, what does the surgeon do when we talk about spread? And I'm talking about something beyond the lymph nodes. And so many of your questions are related to that. I expect Sheree and I will answer some questions for you in the next break about what happens when it gets to your liver. So the biggest thing for us is that you really, again, I don't know if you heard me say this once, but I'll try to say it again. The whole point is you need a team. For hopefully not the Leafs, but there are more teams than just the Leafs in Toronto. On the other hand, if you're going to go to surgery for this, if we are going to try to help you get some of these liver mets out, it's not, just having a slick surgeon is not all that you need. Here I'm showing you a protocol that came up from our anesthesiologist, specifically our current anesthesia-in-chief, who's interested in this. And basically there's an algorithm of how you use hormonal control during surgery to protect you and protect all the hormones that flush out when I'm doing things like squeezing the tumor. So that's one part of it. The second part of it is planning. So we kind of got to know how to get this out. This is one of our radiologists who has an interest in it and making these little models. I can't make it move around and spin like that, but I can tell you, he can tell me exactly how much volume of tumor that you need removed. We can use that to look at a prediction of how you're doing. And over the years, we've been able to use this to redesign our surgery. In fact, the surgery for neuroendocrine tumor in the liver is very different than the kind of surgeries you would do for somebody with colon cancer. So if one of you have a friend with colon cancer who's had liver surgery, don't start comparing notes. You're going to feel like one of you got ripped off. Neither of you got ripped off. You just had different surgeries for different things. Colon cancer tends to spread into a section. It needs that section usually removed. It has lots of studies to show that that's effective. With metastatic neuroendocrine tumor, a lot of times it doesn't spread in the same way. It's often spread a little bit more to both sides. It's spread a little bit more generally. And what we can do as surgeons is in fact what we want to do is preserve as much of your normal liver as possible. Because if I get rid of too much of your liver, I affect you for your future options, which you're going to hear about and you heard about a bit already. And also, we want you to have a good quality of life. And unlike colon cancer, we actually have more therapies directed to the liver than just surgery, so we can give you other things. And so it's important to come up with a composition of treatment. We also get to do cool things. This was a project we did to we hacked a Connect machine, so we could just hand signal a computer and it would move the images with us as we operated on your liver. So these are kind of more sophisticated things that we do. And why? Is so that we can do something like this on a Friday afternoon, which was, this says bottle number 50. That's the number of tumors we took out of an individual person. Unlike colon cancer, we don't take out a section of your tumor, of your liver. We take out the spots out of your liver and we leave as much normal liver behind. This is also a very effective way to get a thanks, or, well, I won't wear the swear word, of your pathologist if you send them this on a Friday afternoon, as I learned when I sent that over. But all of this, just to very quickly, once again, to emphasize it, when we were starting all of this, we did go back to our patients and we did this little study and we said, how do you feel about this? Or how do you feel about your treatment with neuroendocrine? And I mean, the bottom line is that I think there was pretty consistent complaints. This was sort of an open interview with quite a few of our patients. And really, they talked about all this difficulty about diagnoses, different advice, etc. And so one of the important things for the future of surgery is to take the typical hospital situation like this and do something with it. So this is Sunnybrook. It's a big, scary place. You do everything and anything here. You hear crying babies over here. You hear crying adults here with their broken bones. You hear people just crying because they've been in the MRI for 45 minutes over here. The usual thing. So there's so many things going on. And then when you look at it from above, when your doctors are spread out over the campus, we realize that people walking from here all the way to here, this is the cancer center down here, that's not very good. This is where you get your scope. So what we did was we put the ambulance garage right here so we could pick you up as you ran out of breath to drive you to the cancer center. Okay, no, but I mean, we got to do something better than that, right? So even if you have a fancy hospital, it's not enough. So we, with the help of the Leslie family, help create an integrated clinic, which we're still working on now. The whole point of this is to bring all the care here so that when patients are faced with this kind of thing, where you have so many treatment options and you really need these options to do it right, to be able to at least say, take all of this and make the decision just in here, in one consistent place. And we brought the doctors to the patients. You can imagine how popular that was. Doctors are used to having their own schedules. Now we said, there's a neuroendocrine clinic, somebody has to come. So we're trying. Is it perfect? No. Are we there yet? We're getting there. So I'm glad about that. The whole point of this was to create a communication all around our patient. And I think for surgery, it's not just about cutting you. It has to be about the fact that every option has been put in. And surgery, I need to emphasize, is part of the whole plan. It works great when it's part of the whole plan. So, on that note, after giving you that background, then I can explain what questions to ask before and after. So now that you understand that better, these are the typical questions. I think I've given a PDF version here to CNETS, but I think these are important things to know. You should first, and you heard it earlier today, do you really actually have a neuroendocrine tumor? So that's a really important question to ask. Sometimes if you've happen to have surgery in a place that doesn't do as much, there's a lot of partnerships around to the bigger hospitals like in Ottawa or Kingston or London that their pathologists can help make sure they're right. Second thing is, you don't always need a biopsy, but you should at least ask. You know, people were asking, do disease changes? Do they do anything weird? That's important because you want to know that you've got your tumor subtype properly so that you're making the right decisions for treatment. Biomarkers, you know, I think that for many of you, if you're going to the operating room and you don't remember really getting any blood work for your neuroendocrine tumor, you should ask something. The other thing that sometimes we don't, you know, people get so anxious about just getting to their surgery, they forget to ask how to optimize themselves. So optimizing yourself is not to go on like a weird diet where you only wear sandals and only eat the left side of a banana. That's actually bad. You should stay, actually your weight should not go down great, but you should do a lot of exercise. Now, doesn't mean a personal trainer, and it's not a lot of bunch like I look like Arnold kind of stuff. That's not what you want to do. What you want to do, actually, is just be less short of breath when you walk up 2 flights of stairs. That is huge difference to you getting through your surgery. Easy way in the winter is just walk around malls endlessly. Don't window shop, though, because your heart rate goes down, then you don't really exercise. All right, the other thing to ask is, you know, what kind of medication should you be on beforehand? Sometimes you're better to go to surgery after you've had a few doses of sandostatin or had your hormones under control a bit. Even though you're anxious, you want to get there, you want to get those tumors out, sometimes it's much better for you to be in a better, peaceful state in terms of your hormonal activity. You should always know your non-surgical options, okay? Because surgery's great, but you know what? I'm going to cut you. That means something. I go home, I don't really feel anything. Like the tattoo artist said, I don't feel a thing, but you do, and I think it's important for me as a surgeon to know that my patients really knew what the options were, and we made the choice together. This is a kind of disease you've got to do together, okay? That goes to options and risks. What should you expect during your hospital stay, just so you know what's going on, short-term effects, and long-term effects. And those are usually things that you ask before because you're trying to make the decision. I can tell you when you get to the surgery, you're not going to remember that part. So you're going to ask it afterwards. So afterwards, you've got to go over it again. What are the short-term effects? What are the long-term effects? And I think sometimes, you know, surgeons, we're just so happy you're alive and you look okay after the surgery that sometimes we forget to tell you that some of the things you're feeling are actually normal. I mean, patients can sometimes feel like, oh, I'm tired all the time after this liver surgery. I must be petering away. Well, actually, your liver's regenerating, and it's sucking every last ounce of energy out of you. You're actually acting like you were when you were a toddler and growing. And what did you need then? An afternoon nap. So as an adult, you think, what the heck do I need now? I must be petering away. No. And sometimes we forget to tell you those things, and you need to ask. You want to know what your follow-up is setting up. You want to know, do you have any other cancers? And I go back to Dr. Izad, especially if you're a young patient, it's a little unusual. Yes, you got through the early part. Do I have anything else I need to worry about? When should you get your next endoscopy? What kind of dietary restrictions? You know, sometimes there's not restrictions. Sometimes after your liver surgery, for example, I don't actually want you to eat iceberg lettuce for the next month. It might look good, but it doesn't have a lot of the proteins that you need to rebuild your liver. And if you don't feed your liver proteins with this, it will just eat it from this and this. Now, for me, that doesn't take long. But for some of you, it might end up putting you in a state where you're even weaker, and that's silly. So that's no good. You want to know when you can return to exercise, and a lot of times, you can do light exercise. You just got to, for the abdominal sort of surgeries, you got to give that a break for a while, but that doesn't mean bed rest. That might just mean doing the treadmill rather than doing sit-ups. All right? And so that's important, and of course, somebody should be explaining the pathology to you, but most importantly, if you want to know that your pathology was explained to you properly, is that your pathology was put into the context of your next treatment, your future management, and how they're going to follow up. So I think that takes you on to a very, general view of surgery, and you notice I try to stay out of the, we cut the, second vein to the left, and then, like Star Trek, second star to the left. No, but what's important is actually understanding all the other aspects of it. The team, the place to treat, where to put it in, and I think that one thing about surgery, especially if you're metastatic, remember I told you at the beginning, don't just think of cure, think of control. And I think one of the things I always tell my patients is that if I were to give you this deal, if we could keep your tumor under control but couldn't get rid of it, but when you leave the clinic you could do everything else that you want, would that be okay of a deal? And you know what? Most people say, yeah, that'd be okay of a deal. And that's important. But it also means that we need to be thoughtful, and sometimes we need you to be patient with us. A lot of times people come to the surgical clinic and they have one goal on their mind. That is, you're going to open me, you're going to take everything out, and then I can move on. NETS is not quite like that. I wish I could. I can't. A lot of times I'm just one step in your fight, and it's a fight worth fighting, because in between the times that we fight with you in clinic, or in between the times that you're having a kind of surgery, there's a whole bunch of life to live. This is one unique thing about this tumor that I really don't want people to forget. The final thing, you need a team, and the team needs you. We want you to be well informed. We want you to think about these options. There are a lot of options in neuroendocrine tumor. It's important that we know that you've chosen it well. So honestly, this is the best job that I could have. I am very grateful to do this, because I'm grateful that people like you allow us to participate in your care and allow us to really try to do something to help you. This is a tough nut to crack sometimes when we're in more advanced states, but it is a place we can make some victories. And for a cancer treating specialist like me, that's worth everything in the world. Thank you very much.
One of the things that I've been reminded to remind you about are the two forms that you were given when you walked into the room. One of them is an evaluation form, and one of them is a survey. Sherry is going to be blocking that door as soon as you get the okay to go, and she's not going to let you out until you have actually completed those forms and handed them to her. So Sherry, could you stand up for a minute so they know what you look like? There's Sherry, our lovely Sherry. Please be sure to hand your forms to her. Okay, we're going to move on. We have our final speaker for today. And our final speaker is Dr. Jean-Mathieu Beauregard. Dr. Beauregard is a graduate of medicine from the University of Laval. He contemplated his residency training in nuclear medicine and obtained his master's degree at the University of Sherbrooke. He began his practice as a nuclear medicine physician in Quebec in 2006. Dr. Beauregard subsequently undertook a 3-year fellowship at the Peter MacCallum's Cancer Centre in Melbourne, Australia. This is where he gained his expertise in molecular imaging and radionuclide therapy for neuroendocrine tumors. Dr. Beauregard is a clinician scientist. His clinical and translational research program aims to improve the outcome and quality of life of patients suffering from NET through radionuclide therapy, personalization, and combination with novel potentiating agents. I'm having fun. In 2012, Dr. Beauregard has started a radionuclide therapy program supported by a multidisciplinary team. Please welcome Dr. Beauregard.
Thank you, Pierrette, for the introduction. Okay, so the objective of my talk is simple, is to get an overview of the diagnostic and therapeutic procedures nuclear medicine has to offer to patients with NET. So first, what is nuclear medicine? Most of you would have an idea. It's the medical use of radioactive compounds called radiopharmaceuticals or tracers for diagnosis or therapy. The diagnostic procedures consist of imaging the distribution of the tracer in the body, while the therapeutic procedures consist in delivering targeted internal radiotherapy using those tracers that can be also imaged. So basically, in nuclear medicine, what you see is what you treat or can treat, and if you don't see it, you can't treat it. So to compare nuclear medicine with other forms of radiological imaging, radiology in general is mostly like anatomical imaging, and it's mostly like looking under the hood of the car. So you can see all the parts of the engine. You can see if it's the good parts at the good place or if there are parts that are wrong or that not supposed to be there. But you don't know if the car is working or not. Just by doing this. What you need to do is to turn on ignition and start the engine, and it's basically what is nuclear medicine imaging is doing. It's functional imaging. It looks at how things works. So what are the differences or similarities between diagnostic or therapeutic radiopharmaceutical? Both are similar in the sense that they use a specific mechanism to target the disease, and both can be imaged with scan or scintigraphy. There are some differences, though. So the radiation type, for imaging, we use rays. They are called gamma rays, similar to X-rays, but that comes from the radioactive molecule. And for therapy, we use particle radiation. And the doses are very different also. We use very low doses of radiation for diagnostic scans, while we use, of course, much higher doses for therapy. So what are the different diagnostic scans that we can do for NET patients? So we can split them in two categories: the scintigraphy, which is, or it's often called the conventional nuclear medicine, or PET scan. The difference between both is the type of isotope we use. And so let's go for over scintigraphy to begin with. So that's an example of a gamma camera. So basically it detects radiation that comes out from the body, and it can locate it precisely in the body in 2-dimension or 3-dimension. And it's sometimes bundled with a CT scan. So at the same time, we do a CT scan, and we can see very precisely where is the the tracer accumulating in the body, or where is the disease, basically. So the most commonly used kind of scan for neuroendocrine patients is, of course, the octreoscan. Octreoscan is the name also of the commercial name of the tracer, is octreotide label with indium-111. It's an analog of somatostatin. It's basically like a radioactive sandostatin. So it's a very, almost the very same molecule that we get radioactive. Somatostatin is a natural hormone that regulates growth and digestive tract function in the body. Receptors for somatostatin are found naturally in various organs, but in much higher number on many, if not most, of neuroendocrine tumors. The octreoscan can be used to detect NET lesions and also to characterize these lesions. So it can answer questions like, is there somatostatin receptor on a particular lesion. Is it a NET? Because when there is a somatostatin receptor on a mass, it's most likely a neuroendocrine tumor. Without even before biopsying the tumor, we can know it's a NET or very likely to be. So a few words about the procedure of octoscan. Well, the patient needs to tell, and most importantly at the time of taking the appointment, if the patient is on sandostatin or somatostatin, because in some circumstances it can interact with the scan and decrease its accuracy. And the scan itself consists of injecting the octoscan, waiting a few hours and proceeding to an imaging session on the same day, and also another imaging session 20 hours later or the next day. In some circumstances or some center, we can also add a third imaging session on the second day, so 48 hours after. So that's how a whole body octoscan looks. So we scan the patient from head to toes, and it shows basically the distribution of the tracer, which represent the darker spots in the liver are metastases. From that, there's also one in the spine that we can see better on the posterior view. So that's a bone metastasis. I believe there's another one here and here in the pelvis. So all these tumors do accumulate, do have somatostatin receptors. And we see also some organs that are not, that is not disease. So that's the left kidney, the spleen, and some liver background in between the lesions. And that's normal, and also some is eliminated in the urines. That's normal. We can do also with the same camera, so instead of scanning from head to toes, the camera can turn around and perform a 3D scan, so it looks like this. So this is one slice of the body, and that's the 3D representation. So again, we see with more contrast, with more accuracy, the liver lesions here. And with the newer scanners that also have a CT scan, we perform a CT scan and we can fuse both images. So we put the NucMed images in color, in rainbow color in that case, and superimpose it on the CT scan, and then you can see precisely where the lesions are located. The other, another kind of scan that is commonly performed for patients with NET is the MIBG scan. So the name, it's meta-iodobenzylguanidine, which is labeled with iodine 123 or 131. So the iodine, so the I stands for iodo or iodine. So that's the I is the radioactive bit of the MIBG molecule. It's taken up by neuroendocrine tumors, which produce hormones in the amine family, and the most common one are adrenaline for pheochromocytoma or other related tumors, and serotonin for tumors, small bowel tumors or carcinoid. And again, it's used to detect and characterize NET lesions. The preparation, for the preparation, patient will be asked about his or her medication. It's sometimes necessary to suspend some drugs that can interfere with MIBG uptake in the tumor. Patient is advised to take Lugol or iodine solution 2 days prior and 2 days after, or sometimes more after the scan, and that's to protect the thyroid gland in case some iodine detached from the MIBG molecule, and then it would go in the thyroid and deliver some radiation there. It's again consists of an injection and an imaging session. The protocols may vary from center to center. Some would do a scan on the same day. Most center will do only on the next day, so 24 hours later. It can be later also, depending on the type of iodine. If it's 123 or 131 that is used. And also we can, and most of the time we will have a whole body scan plus a SPECT scan, so that's the 3D scan, and with a CT scan if the camera is equipped with it at the center you're doing your scan. So again, we see the distribution of the MIBG. It's similar to the octreoscan distribution organ-wise. So you see the liver, the spleen, and much more faintly the kidneys in this case, and very dark spots that do represent in this case, some lymph node in the abdomen and thorax metastases, probably in the bone in this case. Occasionally, we would perform also bone scans. So it uses a tracer that binds to bones. It's labeled with another kind of isotope called technetium. It detects tumors in the bones. It takes about 4 hours for the complete procedure from injection to imaging. It's occasionally used in patients with NET disease because NET spreads to bone less frequently than other common cancers. And then the PET scan, so PET stands for positron emission tomography. So the radioactive atom in these tracers emit a positron, which results in two rays, so that it can be detected on a ring detector. So, but from it looks very much like a CT or an MRI scanner. And nowadays, the PET scan was performed in the 90s, and since 10 years, about all the PET scanners are PET-CT. So it's always, when we talk about PET, it's always nowadays a PET-CT scan. So that combines also the CT images and fuse them with the PET images. The most commonly performed scan for all cancers confounded is the FDG scan. FDG stands for fluorodeoxyglucose, which basically is radioactive sugar. So it looks at how much glucose or sugar tumors are burning. So the more they are aggressive and active, the more they light up on this scan. It's used only for selected patients with NET disease, because most of the NET are well differentiated and slowly progressive, so they do consume less sugar because they don't need as much as other aggressive cancers to grow and proliferate. So an example of this would be a tumor that is seen, that we know it's a NET tumor, that is seen on CT scan or MRI, but the octreoscan is negative. Then we can be worried that this tumor is dedifferentiated, so it lost its somatostatin receptor and is more likely to grow faster and to light up on FDG, and then we can use that information to tailor the treatment. And it can also be used in some circumstances to assess response to therapy. For this procedure, fasting is needed. It's about a 2-hour procedure. And here we can see in color, here is the distribution of the FDG or the sugar in the liver metastases of a patient with NET. And it's superimposed on a CT scan, and that's the 3D representation of it. And then many of you have heard about the gallium-68 PET scan. Well, when we talk about gallium-68 PET scan, we refer to somatostatin receptor PET scan, and it uses various somatostatin analogs, all labeled with gallium-68. It can be octreotide, octreotate, Dotatoc, or Dotanoc. It's not, some are synonyms, but it's all variation on the same molecule. It's all, they are all derived from octreotide, which is an analog of somatostatin. And it's the same, basically it's the same thing as having an octreoscan, but it's faster. The complete procedure is completed in 2 hours instead of 2 days. It offers higher resolutions and sensitivity. It's really a high-performance octreoscan. However, and unfortunately, the availability is limited in Canada due in part to stringent regulations and lack of industry backing. So NET is a rare disease. We are a small population in Canada, so there's not much industry willing to invest to get gallium-68 agents on the market. And also there's some logistical challenges because gallium-68 is a very short-lived isotope. In fact, the half-life of the gallium-68 is 68 minutes. It's not because of that, it's called 68. It's happened to be a coincidence. So basically, if you have that amount of gallium-68 and you leave it on the table, 1 hour later, you have half of it. So it cannot travel very far for gallium-68 agent to be synthesized in a place and be shipped over many hospitals far away. However, the relatively good news is that octreotide is not that bad, actually. And for most cases, the vast majority of cases, octreotide provides the adequate and diagnostic information we're looking for in terms of taking the management and therapeutic decisions. So now about radionuclide therapies for NET. The goal is to deliver radiation targeting as much as possible the NET lesions and sparing healthy organs. Radiation will cause greater damage and kill the tumor cells and cause little harm to the organs. And the maximum therapeutic benefit may take weeks to months after the therapy to manifest. And basically, that has to do with NET being more slowly proliferating, so the tumor will basically, after receiving the radiation, they will have damage to their DNA and they will die at the time of dividing. And because NET are dividing slowly, it takes long to a few weeks or a few months, if not many, to see the effect. And it's intended for a patient with metastatic or unresectable NET disease. And most of the time we'll wait before giving radionuclide therapies until there's progressive disease despite optimal medical treatment, or where there are symptoms uncontrolled by conventional medication. And it's a palliative treatment modality, not a curative one. So there's two kinds of radionuclide therapies. There are the systemic one and the local regional ones. In the systemic ones, the tracer is injected intravenously, circulates in the body, and accumulates preferentially in the tumor lesions wherever they are in the body, and that's the case of PRT and MRBG systemic therapies. And the original therapies is when the tracer is injected in the liver artery and accumulates more in the tumor lesion in that organ than the organ itself, and that's the case for yttrium-90 microspheres or radioembolization. So now about PRT. PRT stands for peptide receptor radionuclide therapy. All the tracers are analogs of somatostatin. Somatostatin is a small protein that is called a peptide. The eligibility is mostly based on tumor visualization on octreoscan or gallium-68 PET scan if available. And basically you can treat with PRT if you can prove there's a presence of functional somatostatin receptor on the NET lesions. So the tracers used for PRT in the 90s, when it began in Europe, it was with indium-111 octreotide. So basically octreoscan, but given at high doses compared to just the diagnostic scan. Indium-111 has a very short-range particle radiation. It had limited efficacy, and today it's rarely used. Then the centers in Europe move on to yttrium-90 octreotide, or it's called often DOTATOC. Yttrium-90 has a much longer particle range, so more powerful radiation. That was more effective, but unfortunately, it's also associated with slightly more toxicity. Not that bad, though. So that today it's still used, but only in selected cases. And today's the preferred agent is lutetium-177 octreotide. This dotatate is a synonym of it, and lutetium has a medium-range particle radiation, which is the right balance for efficacy and toxicity. And as I said, it's now the most popular PRT agent. The typical way to administer lutetium PRT is to give initially 4 cycles every 6 to 12 weeks apart. It can be administered as a daycare procedure, although some center would prefer to keep patient in for 1 day. It needs administration of pre-med, mostly an anti-nausea pre-med, and also amino acid infusion over 4 hours in parallel to the lutetium injection. And amino acid is to protect the kidney from radiation. And the intravenous administration of lutetium octreottate, which takes about 10 to 15 minutes. And the nausea comes mostly from the amino acid, more than the lutetium itself. And then the patient would undergo one or more scans following each cycle, typically at 24 or 48 hours. And in some protocols, like ours, we scan up to 3 or 4 days after to measure the precise amount of radiation going in tumor and organs. Lutetium PRT is well tolerated by the vast majority of patients. Acute side effects may include some nausea, pain, or increase in hormonal symptoms for those patients who have some. However, like I said, the majority of patients would feel absolutely nothing. Also, we can see some fatigue, just general mild fatigue over a few weeks. That's another common side effect. We need to monitor the blood counts during the following few weeks because the platelets in particular, they can go a little bit down. However, most of the time we just follow that and we do nothing about it, and the platelets or any other blood counts would recover before the next cycle. The main long-term side effect is a mild decrease in renal function, although it's seldom severe enough to require dialysis. Severe renal dysfunction on the long term happens only in 1% or less of patients. So about the efficacy or the outcomes of lutetium octreottate PRT, there's a benefit in about 2/3 of patients. In terms of tumor size, so about 1/3 of patients would have tumor shrinkage, rarely tumor disappearance. And 1/3 of patients will have tumor stabilization, which is it's seen as a good outcome, particularly if there was a tumor progression before the treatment. And because it's a palliative treatment, the quality of life is a very important endpoint, and about 2/3 of patients with pain or hormonal symptoms will have a reduction in those symptoms in terms of intensity or frequency, or the medications to control those symptoms can be tapered down or withdrawn. So like I said, it's a palliative treatment which improves quality of life, and there has been data about this that prove this, and it seems to prolong survival, although there's no robust data like our oncologists or colleagues like to see. So that would compare with in a randomized setting with the standard treatment. This has not been yet. If there is any benefit in terms of tumor shrinkage or stabilization, in terms of hormonal symptoms or pain symptoms decrease, or also benefits in terms of biochemical markers like chromogranin A going down. So if we can see any benefit of the PRT after the four first cycles, then we would deem patient eligible for what we call maintenance cycles, which is typically one-off cycles given every year, but the interval can be adjusted according to each patient's situation. Some patient would have one cycle every 6 months, some it could be 2 years or even more. If the disease is perfectly stable, we can wait for longer. And then patient can have, as long as there are benefits and they tolerate well, they can there's no really limit on how much we can give in the lifetime. I've seen some cases having up to 17 cycles over a 13-year period, so it can keep the disease controlled for a long time. So this is an example of a nocturo scan before and after lutetium octreottate therapy. So before you can see many dark spots in the liver. Actually, that's the very scan I showed you as an example of octoscan. And then 3 months after the 4 cycles, we can see that the liver mets or metastases have disappeared, or at least their uptake is not higher than the normal uptake of the liver. And also, we can see a marked reduction in the uptake of the bone metastases. So the disease is still there, but it's under control. So what's the situation in Canada about PRT? It's currently available under clinical trials at the London Health Science Centre and also at the Edmonton Cross Cancer Institute. Currently, it's available also at my center, Sud Quebec in Quebec City, under the Special Access Program, and soon under a clinical trial. Health Canada will close definitely the Special Access Program in a few months' time. So we do the quickest we can to start our trial, like did London and Edmonton. And soon it will be also available under common trials in Ontario involving London, but also the PMH, Sunnybrook, and Hamilton Centre. And now a quick word on the MIBG therapy. It's the same tracer as the MIBG scan, but always labeled with iodine 131, which has a particle radiation, and of course given at much higher doses than we would for a diagnostic scan. And the eligibility is based on the MIBG scan. It must be positive before we give the therapy. We give also iodine or Lugol solution as a pre-med to protect the thyroid gland. Hospitalization is required for radiation protection purposes because there's a higher rate of external radiation, so rays that goes outside the body of the patient, rays that are good for imaging but are not good for the people around the patient. So we keep the patient in for just a few days while these amount of radiation are higher. And blood pressure must be monitored during MIBG administration because it can go up. And we scan patients about a week after the therapy, and it can be administered as multiple cycles as well as lutetium can. It's mostly useful in pheochromocytoma kind of NET or other related tumors such as paraganglioma or neuroblastoma in the children. It's also an alternative radionuclide therapy for selected cases of carcinoid NET disease, particularly if the octoscan is negative but the MIBG is positive. There's less radiation to the kidney following MIBG therapy than there is during PRT, but there is more to the bone marrow, so MIBG tend to cause more hematological toxicity, which is basically drops in blood counts. So this is an example of three MIBG scans after 3 treatments of MIBG in this patient. So you can see the liver is quite dark, so there's many mets, and it tends to somewhat be controlled or shrink a little bit over the time. And a quick word about the radioembolization with yttrium microspheres. So it's basically small beads of glass or resin to which yttrium-90 is bound. It's suitable for patients with metastasis in the liver only or mostly. It needs the placement of a catheter in the liver artery by a radiologist, so it's slightly more invasive than PRT. The radioactive beads are injected in the liver artery, so they are trapped in the smallest blood vessels. And they do accumulate more in the metastases than in normal liver because the liver artery provides only 25% of blood flow to the normal liver, but 100% to the metastases. And also we can image the distribution of these, but I don't have any picture. There are some contraindications such as poor renal function, hepatic function, or blood shunt. That means some blood that goes directly from the liver artery to the lungs, for example, that skip the liver. So if that happens, we must abstain from giving such therapy. The side effects, it can worsen liver function, although severe liver toxicity is rare. Complications in less than 5%, and it's mostly gastrointestinal related. Yttrium-90 microsphere is showing promising results and efficacy in the same range as PRT, but again for disease that is confined to the liver. So in summary, nuclear medicine for neuroendocrine tumor can offer diagnostic scans, which are functional imaging and that assess non-invasively specific features of NET, and scans that are complementary to radiological exams such as CT scan or MRI. We can also do radionuclide therapy that uses specific features of NET to target tumors with radiation, using the unique what you see, what is what you can treat approach. It has a complementary role to other medical and surgical therapies. It's well tolerated and shows promising results. And the nuclear medicine physician is now a key player in the multidisciplinary team for the optimal and personalized care of patients suffering from NET. Thank you for your attention.
Thank you very much. So if we could have all the doctors come up here, and then we'll do the Q&A quickly. We are running quite behind. So we get at this. Really good. Okay, do we have any questions?
Afternoon. Given the innovative approach and the special needs of this interdisciplinary approach, are we going to? How do people in the province, in a more widespread, Toronto's great, perhaps Quebec City, wherever. London was another one, I believe. How do people access that quality of care that are not living or not proximate to those areas? Often people in smaller communities just can't access this type of.
So I want to take a stab at this one because Sri and I have been working on the project, but there's some good news for you. You should see how good Rachel looks on TV. Now, what I mean by that is we see her once a month because we know this is a difficult thing to treat. So we've actually used the Ontario Telehealth Network to create a monthly multidisciplinary case conference. And what this means is that doctors from any hospitals who's connected to the OTN, which is basically all hospitals, can call in monthly and have their case presented. And the technology is pretty cool. So no longer do we have to send CDs of people to each other. Whichever site can load up the images and show everybody else. There's some resolution issues, but at least we can bring our more complex cases, discuss it together, and so we have a forum to do that. Now, every center has their own multidisciplinary case conference where basically it's a bunch of people talking behind your back, but it's actually for your own good. But what it means is that those complex cases are raised, but we save some of those cases for these monthly rounds, and we do them very regularly, and that's been happening for well over a year now. So that's one way we can help bring that kind of care to anywhere in Ontario.
Let me just add a point to that, and obviously Calvin has given you sort of a bird's eye view of what's happening. Beyond that, Cancer Care Ontario now is actually stipulating that every cancer center will not receive funding unless they satisfy certain requirements. And one of these essential requirements are multidisciplinary tumor boards on a regular basis. They haven't gone yet to the point where they're insisting on what Dr. Law was talking about, which is multidisciplinary teams from different centers talking to each other. My suggestion, and maybe this is a gentle suggestion, while many of us often are talking about having a second opinion, much easier for you is actually to be able to ask, has my case been reviewed at the local multidisciplinary tumor board? and what was the outcome? And secondly, did the local tumor board discuss the possibility of taking it to the provincial tumor board? Those are two very simple questions. It doesn't cost you anything. And in some cases, maybe the people who are involved are not even aware.
Just one little follow-up. It was interesting when you were speaking that you, at least to me, that you mentioned about, despite all the diagnostic treatment or modalities and so on and so forth, but you said, I don't want to lose sight of the whole person, the outcome, how is that person doing? And it's nice to hear from people who are so enthusiastic and involved, and this is your whole life's work, that you remember that it's a person on the other end of this thing that's suffering with whatever, diarrhea, or I think we tend to lose sight sometimes of the personal aspect of it.
And their families, I might add.
And their families. Yeah. So thank you for mentioning that. Yep, sure.
Could you tell us a little bit about the differences in Quebec and also how, if at all, the two provinces communicate on this issue?
Sorry,
how Quebec and Ontario communicate about NETs?
From my perspective, I already communicate or we are discussing issues in our respective trials. So we try to synchronize our efforts to give the same best care to all Canadians, including PRT, in which I'm involved.
So Dr. Beauregard is being very modest here. He's probably one of Canada's most important rising new stars in this field of medicine. He didn't really explain to you, so I'll take the opportunity of saying this out loud. What he has studied for many years is actually the different approaches of being able to measure how much of the radiation that we give in actually gets taken up by the tumor in different regions, and comparing that with what happens in normal tissues. The idea here is to create a favorable balance of targeting more of a tumor while not creating damage in the normal tissues. And that's a form of internal dosimetry, something that we rarely do actually in Canada, and is very, very unique to the system, and we're lucky to have him. We also are trying to establish similar collaborations in British Columbia as well as in Ontario. So really what we're doing is that even though we don't have any provincial support per se that says, here, you guys go get the best people from all over, we are really almost on an ad hoc basis now trying to capitalize on expertise such as Dr. Beauregard's to be able to pull together an approach that puts together what we feel is going to be probably one of the best peptide radioreceptor therapy trial that's ever been done. It's taking a lot of time, it's taking a lot of effort because we're trying to do it right. And if we do it right, not only is it going to, I think, benefit us in terms of learning how to do it best, maybe even better than other countries, but more importantly, that it's going to be equally as accessible to people across Canada.
I'd like to know what the difference is between a clinical trial and a common trial.
There's none. I would say should have said maybe multi-center trial. Yeah.
So the same criteria and protocols will be done.
Yeah, any trial in humans has a very particularly radionuclides is very complex to set up, particularly because there's no industry backing. Usually it's companies that pay for all this to set up to happen. Now we must do it on our own with limited resources, and this is because the NET tumor is rare. We are a small market. There's a large phase 3 trial of PRT going on in Europe and US, but it's because it's a large market together, and they were not interested to include Canada. All the paperwork at Health Canada just for a few more patients compared to their population they serve in Europe and US. So it's more complicated also because it's a radiopharmaceutical, and each center that is doing it is considered a drug manufacturer. So you have the lot of paperwork to fill in and so on. So that's what are the real challenges, and it's also because it's a specific treatment for NET. It's not like the big molecules like we discussed, Afinitor and Sutent, that were designed as anti-cancer drug in general, and then all the companies are doing is adding another indication, but the drug is available already, and they just expand their market. The PRT is just for neuroendocrine tumors, so it's a very small market. So that's why it's so long and difficult to get through these hurdles. Sorry?
Mention it's a registration trial that we're after.
Yes, and we're trying to make it worthwhile by setting up a registration trial that could lead to full approval of the treatment in Canada, despite this lack of industry support.
Thank you.
My question's for Dr. Beauregard. Does the lutetium target bone mets?
Sorry?
Does the lutetium target the
Yes,
bone mets?
anywhere where there are tumors with somatostatin receptor, the lutetium will find them.
Okay, and the MIBG targets bone mets as well?
As well. It targets the tumor wherever it is.
Okay.
Often when we patients get together and we discuss our disease, I hear this kind of story, and I would like to hear a comment from each of you, if you please. Patients will be saying, I haven't been feeling all that well for quite some time. I know I have many mets to my liver. I think they're very small, but I'm on a wait and see. So I'd like to understand, why are we on a wait and see? Are they operable? What would you suggest, Dr. Law and Dr. Beauregard? What I often say is, I wonder if PRRT would be for you. I have no idea. So if we could hear from you.
I love it how Shereen shifted the microphone to me first. That was good. Okay, so those, like, we hear it too. And I have to say that it's difficult because it's a little bit different in everybody, but let me try to be as general as possible. A lot of people, I'm going to give you the typical scenario that's a little bit harder. So it's small mets and it's spread throughout the liver. Let's say they're all little tiny spots. The hard part for us is that with surgery, I'm better at taking out there's different patterns of liver mets, by the way. So the pattern where you have a larger met that's sort of in an area that's kind of pushing on the liver is much easier to operate on than little spots sort of deep in the liver. And the reason for that is, remember I said I was trying to preserve your liver. So if it's small and spread out through the liver, removing half the liver is not really going to help you because there's still little spots on the other side. To go in and dig each of those little ones out, sometimes we can, but if they're deeper in the liver, it means that we have to do quite a bit of damage to get in there to do that. So a lot of times, and it's particular to each patient, we have to customize it. So a lot of our patients, for example, undergo an embolization procedure first. That could help give us an estimate of how things are treated, or sometimes they do the opposite. Let's say they have a lot of small spots, but they have some big ones, and if their primary is still in, we sometimes take the primary out, take the large lesions out, let them recover, and then embolize them. So there are treatments like that. But then sometimes there's people that are just sitting out there, and they're in this kind of place where the tumors aren't really growing, their biochemical markers aren't really high yet, and the lesions are kind of small. And really, you know what we're struggling with? We're struggling with whether the side effects match the treatment efficacy at the time. So I hope none of us just sort of come in and say, oh, you're not ready for treatment and leave right away. We want to hear from you a little bit more. And ironically, sometimes your symptoms can be treated in different ways. And it may not, a lot of times we associate our symptoms with targets that people talk about on the scan, but it may be from something else. And so it's really important for us to sort of do it together. The other thing is that sometimes we don't talk about each other's symptoms as well as you'd think. So what I mean by that is sometimes we go in and all we're doing is talking about the testing and not thinking so much about how you're feeling, which is why I do support strongly people filling out what they call this symptom screening score that every Ontario centre has, and I know that some doctors agree, don't agree, some patients who want, don't want. I mean, I've had patients write on the symptom screening, "You are freaking me out, making me fill this out," but it's not. It's because sometimes we're so focused on tests. It's nice to have this score. And the other thing is, as you do it more and more, I can actually tell you whether your fatigue level is going up or going down, and those patterns sometimes trigger something for me to ask you more, and we can fix things. Otherwise, I hate to say it, even we get stuck in the, congratulations, last time it was a 1.9 millimeter maximum, 1.9 centimeter maximum lesion, now it's 1.8, and it's probably the same, not crazy. Okay, have a good day, and, we feel good, we thought you were okay, but you may have had other issues that we just didn't recognize.
Let me just add to that, and then I'm going to get Dr. Beauregard to comment on radiotherapy. The conundrum that we often have as physicians, to be honest with you, is the following, is when things are stable, we always say, why do you want to rock the boat? And then when things are progressing, so we say, oh, well, we're gonna do something when things start to progress. And when they start to progress, we say, oh, no, it's progressing, so we really have to be careful. I'm just sort of giving you the other side. So really, ideally, it's we're trying to determine three things. What's the optimal modality of treatment? What's the optimal timing of that modality? And what's the optimal order of using these modalities? And those are the three things that we're perpetually trying to always go back and answer. And I think really the question begs, how do we best measure all those elements that enter into the equation that gives us the green light or leaves it in the pause mode? We don't have a very good answer for that.
Yes, I would just add to Sharon's comments, nothing much, but the challenge is really, as far as I'm concerned with PRT, the challenge is not to administer PRT, that's the easy part, but to decide when is the good time and who is the good patient to administer it to. So far it has been administered under the Special Access Program, so that means when all the other available and reasonable options have been exhausted. So that's why we would, first we need that, so that the other options have been exhausted, and we would treat patients with progressing disease or symptoms. So it can have, the patient can have a very stable disease, but if the patient have symptoms that are not controlled by the medication, it's a good reason to give PRT because it's effective at decreasing those symptoms regardless of the tumor progression or not.
Let me, if I could ask, maybe I'll ask Dr. Beauregard that question, because I think maybe others will be thinking about the same thing. The truth is that so far, where we are now, we're, as I showed in my algorithm, we're keeping this as the option of last resort. We're keeping it as last resort because we've thrown everything out at the patient and things are not working out. But if we can turn it around and if we can identify disease earlier through more sensitive tests, which could very well be combinations of gallium-68, maybe circulating tumor cells in the body. Maybe that way I know that you have a whiff of disease that I'm not even seeing on a CT or MRI. Then I can make this stronger argument and go to Dr. Beauregard and say, I want lutetium for this patient, because then he can give a dose that we call will be ablative, meaning identify all those cells that appear to be occult, meaning that they're not very easily identifiable, but on the gallium-68 and maybe other modalities will be identifiable, hit at that stage with lutetium, wipe that population, and not worry until you come back and the disease is all over the place and we're worried whether you're going to be able to handle the treatment or not. That maybe this is simplistic, but if you think about other forms of dosimetry-based, including thyroid cancer, do you want to comment on that?
Yeah, well, that would certainly be interesting subject for future research. Personally, I'm not convinced that it can treat microscopic disease, and we would.
Assume that you can visualize it, though.
Yeah. So maybe, but we don't have much data to support this at the moment. But when it will be approved, then we would have time to explore those new avenues, of course. Yeah.
Dr. Beauregard, when I thought I understood when you said, when you were speaking about metastasizing to the bone, that was not unusual or usual for NET?
It's not unusual, but it's less frequent than most of other common cancers such as breast cancer, prostate cancer, and lung cancer. So these patients may have, if they are at high risk or they have MET, they would have frequently bone scans. But in NET patients, it happens, but not in the majority. Many patients have METs only in the liver, if not the majority of them.
Okay. And if you get bone mets, I don't have this, but if you do get bone mets, what is that an indication of as far as a doctor is concerned? Does it have any play in?
So let me answer the question from the top. If you compare stage for stage, tumor for tumor, adenocarcinoma, so that's conventional pancreatic cancer, for example, and neuroendocrine is less likely to go to bone. Okay, that's number one. But more importantly, that unlike the presence of bone metastases with other cancers like breast and prostate, the presence of bone metastases in neuroendocrine disease on its own is not, I repeat, is not a poor prognostic sign. Okay? So that's the take-home message here. It is, however, we use it often as an indication that there is disease because sometimes we don't see it elsewhere, like the liver is equivocal or completely negative. But when we do an octreoscan scan and we find that there is disease that's now lighting up in the spine, we know there's disease. But the presence of disease in bone per se with neuroendocrine tumors is not an indication that all is, forgotten. It's not that bad.
I was just wondering, did I understand correctly when you were talking about PPIs? Did you say that they've been shown to cause gastrinoma type 1?
So if you take a proton pump inhibitor for a long period of time, and long period meaning over 3 months, your chromogranin A starts to go up. And if you continue to be on it for a year, your gastrin will go up. And if you have a biopsy, because we asked Dr. Law to go in, he will see areas of thickening and he will see hyperplasia. I'm not sure if that came out clearly, but depending on how the biopsy is done, he's obviously careful enough because he drew you the pictures and he knows where to go and how to sample the affected as well as the neighboring unaffected areas to be able to see whether that continuum is there. That's the whole idea behind the surgeon was actually thinking. However, if you have somebody who just goes in and biopsies only one area blindly and all he gets are neuroendocrine cells, now we have a very big problem because we don't know what we're dealing with. It could very well be something that's much more advanced along the spectrum of benign to malignant and somewhere in between.
My concern was I have a 19-year-old son who's been on PPIs now for almost a year. I had lung nets. He has a hiatus hernia, so he has GERD. And after hearing you talk, I thought, oh my gosh, should we be allowing him to be on this?
So I think it's a very good question. I think, in many instances, proton pump inhibitors, as many of you know, are worthwhile. They're kind of like many other medications. The real trouble we don't know is how safe are they on a long-term basis. And then the question that I have is, why does a 19-year-old have GERD? And why do they have GERD that's bad enough to require treatment? And why is this treatment bad enough that it has to be continued? So all these are unanswered questions that I would want the gastroenterologist to be able to go in a very focused manner and give me some specific answers. Because I don't think that it's right to continue to treat somebody, not any more than I think people should be taking other drugs on a long-term basis without clear-cut indications and endpoints.
Thank you.
Yes, I was wondering, before I was diagnosed with my terminal ileum, I had a biopsy that showed it was a NET. and it showed up on my CT scan but didn't show up on my O scan. And it was only 0.8 centimeters. It had gone to one of 22 lymph nodes. And I was wondering, had it not shown up on my octreotide scan because of its size, or that I didn't have that particular receptor? I'm also wondering now, beyond getting a CT scan as my first test, since my chromogram A has gone